Also, namaskar.
हाँ नमस्कार सुदीप, क्या हाल है?
Namaskar. Yes, sir. Thank you, sir. बढ़िया sir.
कैसा है वहाँ तुम्हारे
अभी बढ़ रहा है
काठमांडू में?
sir. Yeah, it is on rise for last yeah, in Kathmandu it was the days before, but yesterday it
Now,
was
can
on
you hear
rise
me now?
suddenly. So we have.
So now that you have made those changes, now it has come. You know, there was something wrong at your end. Can you see me
Now
now?
I can see you. Yes, sir. Very well. Fantastic.
So something was wrong at your end. Okay.
Sorry. Thank you. Great to see you.
Okay, same
Nice
here.
to see you.
Pleasure.
Yeah.
सर गुड इवनिंग।
Sir, good evening. How
sir,
are you?
Namaskar from Nepal, sir. Oh, fine, sir. Thank you.
Namaste. क्या हाल है सुदीप?
Sir, बढ़िया sir. Thank you very much. Just come back and we are locked down again. This is for 1 week.
No.
Kathmandu.
How many cases you are getting in Kathmandu every day?
Actually, it was Kathmandu is very less, 100 something only. But in whole Nepal last time it was recorded 1,000 in 1 day. So that was the highest ever recorded. So we again went down to lockdown second time in Kathmandu from today. Yeah, for 7 days.
Yeah, live, sir.
Hello, everyone.
Hi. Good evening, Dr. Anuradha ma'am. Good evening to you.
Good evening. Yeah.
Yeah.
I don't see Dr. Amit is not there. Amit Joshi has not yet joined.
Maybe another 5-7 minutes.
Okay. Hello, Dr. Anuradha.
Yes, madam, I am here. How are you doing?
Yes, I hope Delhi is safe. Here the incidences are increasing.
Delhi is safe. You know, hospital is safe. Dr. Rawal is taking good care of us.
Okay.
Thank you, sir. It's everyone's effort. We actually have peaked and now come down, but the rest of Delhi is going up.
So, Tarun sir, can we start or wait for someone?
डॉक्टर मेहता,
हाँ जी सर, बोलिए।
ये इन वेबिनार्स ने वीकेंड बिल्कुल मतलब खत्म कर दिया। So every weekend, Saturday evening, one has to sit in front of computer and either speak or listen.
Start refusing.
मुझे तो लगता है सर कोरोना खत्म होने के बाद भी कहीं ये कंटिन्यू ना रहे।
नहीं फिर नहीं रहेगी।
This is second pandemic.
Yeah.
क्योंकि it's very easy to organize this webinar ना।
तभी तो कोई भी शुरू हो जाता।
हाँ जी, गुड इवनिंग जी।
Sir, Vineet.
Good evening, sir. Good evening, Dr. Rawal, sir.
Good evening, Vineet.
How are you?
Yeah, fine. We're waiting for you.
Yeah. There's some problem in the login ID, so it got sorted out. Good evening, Dr. Chogle.
Yes.
How are you?
I'm good. How are you?
Nice to have you. Colonel is there. Colonel, you can show your face. Huh? No, he's not joined or something.
Hi Vineet, hi
No,
Anuradha.
I'm right here.
Yeah,
Trying to
yeah,
find
yeah.
my video.
No, we would like to see your face from straight away from Muscat.
Yeah, I would love to show my face, but where the hell did my video icon vanish?
Hello, Shubhra. Good evening. How are
Good
you?
evening, sir. I'm good, sir.
Hello, Shubhra. How are you?
Good evening, ma'am. How are you, ma'am? I'm fine.
Yeah.
और
Fine.
अमिताभ
So call so.
अभी
So
उधर ही है, अभी घर पहुंच गया.
नहीं नहीं सर, यहीं पर रहना पड़ता, घर में बच्चे हैं ना.
अच्छा. वो बोलते हैं यहाँ तुम्हारी शक्ल आएगी या बच्चों की आएगी.
There are many incidences happening in Tata Hospital for COVID-19.
So, is Tarun there?
Yes, yes, sir.
Hi,
So
Tarun.
Tarun,
we
when do you plan to start?
right away, sir, it's 6:25. I think if
Dr.
doctor
Nikhil
should,
has
if you
joined.
permit.
Nikhil, good evening.
Hi sir, good evening. How are you doing?
Bas ji, badhiya, first
How is
class.
everyone?
The new normal, you also are there like that. We are also there like that. So, any respite or is the same?
The hospital cases are slightly coming down, but the districts are right now going up in terms of the patient numbers.
I see.
So still the hospitals, I mean, we are struggling with the number of patients for sure, but not from the city as of now.
I see. Chalo, that's good.
So Anuradha Chokle ma'am, Dr. Amit Joshi is also there. So other chairpersons are there. So
Okay.
Vineet sir, all up to you. We can start, and Dr.
Yeah,
Shukla
please,
is also there.
please.
I
Already
think
113
Dr. Amit,
participants.
yeah, Dr. Amit can take start with the this introduction, and I will give some my remarks at the end of the
So
Dr.
I can't see Dr. Joshi. Dr. Joshi, good evening.
Good evening, Dr. Vineet.
जरा झलक तो दिखा दो.
नहीं मैं घर में हूँ. I am at home.
हाँ ठीक है. Most of us are at home. Dr. Bharat, how are you? Chalo, I think we can start. So,
Yeah, it's 120 almost participant.
Dr. Amit Joshi, you can start with the introduction.
I think I'll request Dr. Shubhra to start the proceedings, and then obviously we can take forward. Dr. Shubhra, please take
Yes,
over.
sir. Thank you, sir. Good evening, dear faculty members and delegates. I, Dr. Shubhra Rana, welcome you all for this evening webinar on updates and management of renal cell carcinoma. For past few months, as we were already discussing, the world is at halt due to COVID-19 pandemic, but we didn't stop. We are continuously working, we are continuously providing our services and upgrading our knowledge through these webinars. So this is the time when we are going to update our knowledge on management of renal cell carcinoma. I believe no one of us is not unaware of the name Dr. S.K. Rawal, the pioneer in robotic urogenital surgery, and his expertise in this field. Sir is Medical Director and Chief of Urogenital Oncology and Rajiv Gandhi Cancer Institute and Research Center, Delhi. I request Sir to chair today's meet and to introduce today's topic, updates in management of renal cell carcinoma. So over to Dr. Rawal, sir.
Thank you, Shubhra. It's my pleasure to be in this webinar, and I thank Vineet for inviting me as a, just introductory remark and all. But RCC per se has is a very big role a urologist or uro-oncologist to play in the local RCC, or that is organ confined, and the locally advanced. But metastatic RCC is evolving into a different field. I remember in 1980s when I was doing my MBBS, there used to be a gene named MDR, multi-drug resistant gene, and that was responsible for no effect of any drug in case of RCC. We were taught that RCC is drug resistant. and you just have to do surgery. You can't do anything. Maybe you can give medroxyprogesterone or something, but they don't do well. And then came interferon and interleukin in 90s or late 90s. And then came sunitinib and all VEGFR receptor blocker, then mTOR receptor blocker. And now we have the immunotherapy. Things are changing for RCC. The people who are having advanced disease, they are living like a chronic disease, like they develop, if you give these drugs, so they live very long, sometime even 10 years with especially VEGFR agents. But once the IO have come, the things are further changing, and they are irrespective of any histopathology or anything, they respond to IO. So to update this aspect, we have eminent faculty from country and Singapore also. And I wish that everybody, all the participants, I can see that around 121 participants are there, and they all will get benefited from the talk, presentations, and whole of the program will teach them to everything in metastatic RCC. Thank you, Shubhra. Please, my all the best for this, and have a nice discussion and nice webinar.
Shubhra, you have to unmute yourself.
Thank you, sir. Dr. Rawal, sir, thank you so much for providing us brief overview of today's topic. For our first session on biomarkers and role of TKIs, I invite Dr. Anuradha Chogle and Dr. Amit Joshi to chair and moderate the session. Dr. Anuradha Chogle is professor and scientist in charge of Medical Oncology Molecular Lab at Tata Memorial Hospital, Mumbai. Dr. Amit Joshi is professor, Department of Medical Oncology, Tata Memorial Hospital, Mumbai. Thank you. Over to Anuradha, ma'am.
Hello, everyone. So today we are having an interesting session about the translation medicine and renal cell carcinoma. And Dr. Anurag Mehta is going to talk on the brilliant talk on translation medicine and renal cell carcinoma. I think at the end of the session, I can give my remarks, and Dr. Amit Joshi as well. Over to Dr. Anurag Mehta. I think if Dr. Amit Joshi wants to introduce Dr. Anurag Mehta, he can take it over. Dr. Amit?
Yes. I think I will invite Dr. Anurag Mehta. Hello. I think he's already started sharing. So without wasting much time, he's a consultant at Rajiv Gandhi and a special interest in the molecular biology. So we will get some new insight into the relevance of biomarker in RCC by his talk. It's over to Dr. Anurag Mehta for the talk.
Slight corrigendum. Sir is our director of pathology and molecular lab services. So I think, sir, please.
Thank you, Amit.
He's a brilliant speaker. So we are going to get definitely very good inputs about this biomarker.
So thank you, everybody, and good evening all. And I shall speak to you on the relevance of biomarker in renal cell carcinoma. So every one of us knows that renal cell carcinoma constitute about 3 to 4% of all cancers globally, and they counted for nearly 400,000 new cases and 175,000 deaths in the year 2018 as per the Globocan data. RCC is an extremely heterogeneous disease. And I'm not saying this as a cliche. It is truly a heterogeneous disease. It's a heterogeneous disease in terms of the diverse histomorphology and require very subtle and nuanced approach to histomorphological diagnosis. And there are new entities being added, and 10 to 15% of RCCs are not correctly diagnosed. Even in the TCGA cohort, about 15% of the diagnoses were changed from the submittal diagnosis. It is also a very varied disease in terms of biological behavior. Some people can have an indolent metastatic disease. Others may come back with the local recurrence or metastasis at the first follow-up. There are several clinical and lab-based risk stratification model, but they all have dubious performance with concordance index of 0.58 to 0.68, just about better than a flip of coin. And the RCCs drive themselves through several oncogenic addictions. It may be hypervascular state. They can actually thrive by carrying out immunogenic inhibition, or they subvert metabolism to prosper themselves. So this diversity or this background raises three questions. The question number one is, can we use biomarkers to improve diagnosis? Can the prognostication be bettered by using molecular biomarkers over the clinical and lab-based risk stratification models? And can biomarkers help in selection of therapy? So the journey of biomarker discovery began way back in 1993 with identification of germline inactivation of VHL gene in von Hippel-Lindau syndrome, where there is a estimated 70% lifetime risk of developing clear cell renal cell carcinoma. And by 2001, it was established that somatic biallelic VHL inactivation is virtually ubiquitous in cases of renal cell carcinomas. Over next 10 years, additional significantly mutated genes were identified. And in 2016, we had a new WHO classification. And this new WHO classification, while it retained the three canonical categories of clear cell renal cell carcinoma, papillary carcinoma, and chromophobe carcinoma, it added another category of renal cell carcinomas identified by their genetic signatures. And unfortunately, all these genetically defined renal cell carcinomas do not have distinctive morphology. They have overlapping morphology with clear cell carcinoma, papillary carcinoma, or chromophobe carcinoma. And in this way, WHO for the first time inserted the need of biomolecular testing for renal cell carcinoma. It shall also be noted that about 5 inherited renal cell cancer syndromes have been identified, which account for 3 to 5% of all the RCCs. That may actually be an underestimate, and they also need to be identified. And therefore, the role of genetic signature in classification of RCC became important. Over next 5-6 years, it was seen that RCC with the same morphology may actually evolve through different molecular pathways using different genetic and epigenetic alterations, which may define prognosis, and which can possibly be also used for selection of therapy. And the last 5 years have gone to research on tumor immunity and microenvironment, and to identify the genomic correlates of the host immunity in face of the tumor growth. And these genomic alterations are being used to identify the responders to immune checkpoint inhibitors. And when we come to 2020, there are surfeit of biomarkers. Many are useful. None is fully validated. They have not been validated, at least prospectively. And outside the diagnosis, these biomarkers are seldom used. So let's see, can we use them effectively? So we start again by answering those 3 questions that we have raised for ourselves. So can we use biomarkers to improve diagnosis? And I will give some examples. So here is a case of a radical nephrectomy. It shows a papillary architecture, high-grade nuclear feature. And in a normal course, this will be diagnosed as papillary renal cell carcinoma type 2 with its associated bad prognosis. But we did the genomic IHC for fumarate hydratase, and found that the tumor is negative for fumarate hydratase. And on the other hand, it is showing the accumulation of the oncometabolite called to succinylcysteine. And therefore, the diagnosis now was fumarate hydratase deficient RCC and not papillary RCC type 2. Now, this shall logically lead to germline testing for fumarate hydratase inactivating mutations. And if an inactivating mutation is found in this proband, the testing should be extended to the kindred. Why is it important to identify such cases? Because in such cases, there is no role of observation. These are the cases which undergo early metastasis to bone. Unlike other inherited renal cell carcinomas, where surgery is usually performed when the tumor has grown to 3 centimeter size, in this kindred, if the tumor is seen at any time, whatever size, smallest size, this has to be removed with a good margin. And the fumarate hydratase deficient RCC, if unfortunately they become metastatic, they respond well to specific combination of BEV with erlotinib, which is otherwise not a standard of care. So likewise, we can also identify the RCCs which are deficient in succinate dehydrogenases. Again, test them for germline mutations. We can identify MITF translocated by doing genomic IHC for TFE3 and TFEB. And if we find positive staining for TFE3, TFEB, then one has to confirm this rearrangement of MITF by doing a break apart FISH for TFE3 and TFEB. And if this FISH is negative, then there is quite a strong likelihood that this may actually be a newly defined entity called ALK rearranged RCC. So about 30 cases of ALK rearranged RCC have been defined. They have diverse morphology. They have a signet ring or sarcomatoid or rhabdoid cytology. And it has been shown in anecdotal reports that they show, in terms of the authors of this article, they show profound and prolonged response to alectinib and entrectinib. So there may be a case to diagnose these new entities by using genomic IHCs based upon the newly discovered biomarkers. And now coming to papillary renal cell carcinoma, the WHO classifies papillary renal cell carcinomas into type 1 carcinomas and type 2 carcinomas. But those who are practicing genitourinary pathology will tell you that there are many cases which cannot be put into these two neat bins of type 1 and type 2. In the TCGA cohort, about 15% of the papillary renal cell carcinoma could not be assigned type 1, type 2 classification. So these are the ones which are now called papillary renal cell carcinoma, not otherwise specified. And we have a recently described group of low-grade oncocytic papillary renal cell carcinoma, which has excellent prognosis. So if we see the survival, low-grade oncocytic papillary renal cell carcinoma has 100% survival. Papillary renal cell carcinoma has good survival, while papillary renal cell carcinoma type 2 has the worst prognosis, and the NOS has the intermediate prognosis. And therefore, it is necessary to correctly identify them. And there is this new set of IHC based again upon the genomic identification of these biomarkers. The first is the ATP binding cassette C2, GATA3, and carbonic anhydrase 9. The differential expression of these three markers can actually help us in classifying these entities and thereby we can estimate their associated prognosis. So to summarize, the genomic IHC based on newly recognized biomarker can establish and refine diagnosis in 5 to 10% cases of the renal cell carcinoma. Inherited RCC confirmed by shall be confirmed by appropriate germline testing, and then this testing can be spread to the family members to identify the silent mutation carriers. And papillary renal cell carcinoma can be better diagnosed into prognostically significant categories using a combination of ATP binding cassette-2 protein, carbonic anhydrase 9, and GATA3 IHC. So now we move to the putative roles of biomarkers in prognosis, and we will basically discuss about clear cell renal cell carcinoma and papillary renal cell carcinoma. So as I said earlier, the VHL inactivation is virtually ubiquitous or universal in cases of clear cell renal cell carcinoma. So this study by Dagger shows that about 68% of clear cell renal cell carcinoma have biallelic inactivation of VHL gene, and about 22% of the cases have monoallelic. That means only one allele is inactivated while one allele is normal, and about 11% of the cases have wild type of VHL gene. Now, based upon this information, if the tumor has wild type of VHL or has undergone monoallelic inactivation of VHL gene, it is expected to be a high-grade tumor with sarcomatoid or rhabdoid morphology, with abundant lymphoid stroma, strong staining for VEGF, and the survival statistics have shown that patients with biallelic inactivation have the best cancer-specific survival, while those which have the wild type of VHL have the worst cancer-specific survival. And this information has been confirmed over several studies, most significantly in the TRACER-X renal study. And we will come to that later. So identifying whether the VHL inactivation is biallelic, monoallelic, or wild type is very crucial for prognostication. So in addition to VHL, in clear cell renal cell carcinoma, you can see VHL is basically, like universally inactivated. There are about 9 other genes which are significantly mutated genes. And what are these significantly mutated genes? So these are the 9 significantly mutated genes. Most important of them is polybromo-1, also called PBRM1, lysine demethylase 5C, accounting for about 7% of mutations in CRCC, and this KDM5C and PBRM1 are generally co-mutated. BRCA-associated protein 1, about 15% of the cases show BAP1 inactivation, and BAP1 inactivation is mutually exclusive with PBRM1. About 15% of the cases also show SAT-T2, SAT-D2 inactivation. And all these 4 genes are associated with chromatin remodeling and drive the tumor through hypervascular state and immunogenic state. About 5% of the genes of the PIK3, CA, mTOR, TSC, AKT pathway are involved in RCC, and they drive the tumor through metabolic pathway. And about 10% of the tumors have VHL inactivation alone without an accompanying co-mutation. And these are the tumors which again thrive through hypervascular state. So we have tumors of the PIK3 AKT pathway driven through metabolic subversion, tumor with VHL inactivation driven through hypervascular state, and the others, large number, driven through chromatin remodeling, which utilizes both the hypervascular state as well as the immunogenic state. So now let's look at the role of these additional significantly mutated gene. So it's already spoken about VHL gene. Now let's look at the PBRM, BAP1, etc. So these 2 large cohorts from all stages of RCC showed that patients with PBRM1 inactivation have at least 2-fold longer OS compared to those which are BAP1 inactivated. And this was shown in both the cohorts from the Mayo College as well as from the TCGA cohort. The role of BAP1 has been uniformly been supported as a poor prognosticator in virtually all these studies. So here again, this study, early phase localized RCC, one can see the BAP1 mutated cases or BAP1 negative by IHC expression have far poorer prognosis compared to those which have intact BAP1. And this BAP1 has been shown to be an independent prognostic indicator from Mayo College S sign score, at least in the low and intermediate score group. In another study from University of Tokyo with seminal work, again it was shown that BAP1 mutated or locally advanced RCC have inferior survivals, but the role of PBRM could not be established. This was found, PBRM inactivations were found to be inconsequential. And likewise, many other studies have shown that the PBRM inactivation, at least in the localized RCC, actually confer inferior recurrence-free survival and cancer-specific survival. While the PBRM1 inactivation in metastatic setting treated with standard of care shows better survival outcomes compared to those which are wild type. In this recent publication from Memorial Sloan Kettering for advanced renal cell carcinoma, this one again showed that RCCs with the PBRM1 inactivation have a superior overall survival, while those which are inactivated for TP53 and BAP1 had inferior survival outcomes. And they actually introduced the genetics, these three genetic signatures into their existing MSKCC score, and found that incorporating the information on these three genes into their MSKCC scoring can actually improve the performance of MSKCC scoring for advanced renal cancer. So, and this tracer, which X study, which is a very, very prestigious work, which has done deep genetic and genotyping of the RCC, has shown that patients with multiple drivers, patients with BAP1 inactivation, and patients which are VHL wild type have rapid progressive course, while those which have PBRM1 mutations or are driven by VHL inactivation alone have attenuated or a slow progression. And this is well depicted in this picture. So those cases which are driven by multiple drivers, those which are driven by BAP1 inactivation, or those which are VHL wild type have a rapid progressive course and show metastasis at multiple sites, while those which are PBRM mutated or which have VHL inactivation as a mono driver, they show a slow progression and usually metastasize to lungs only. So while it is suggested that the inactivation or the mutation in these genes should actually be checked on NGS, but IHC is available, though this IHC is fastidious and difficult to standardize. Now coming to the papillary renal cell carcinoma, the appropriate classification is prognostically significant. If you can actually appropriately classify that, that's really, prognostically very, very important. But the comprehensive genetic and genomic typing by TCGA has shown that we can divide papillary renal cell carcinoma into 4 clusters. And there is this C2C cluster, which is identified by CPG, that is cysteine, CPG island in the promoter sequences being methylated, like in the colorectal cancer, we have a SIMP type of colorectal cancers. And here the promoter sequences are methylated in several of these genes, which results in loss of protein expression. And if there is a loss of protein expression of cyclin-dependent kinase 2A, P16, and fumarate hydratase, that basically signifies that this cancer is a SIMP type of a cancer. And the same type of a papillary renal cell carcinomas have abysmal prognosis. Actually, they have the worst prognosis in all the types of RCC. It has also been shown that if we can actually do the expression of LET7 families of microRNA, then LET7 family of microRNA usually show underexpression in PRCC1, while they are highly overexpressed in PRCC2, and this can allow us to neatly bin PRCC1 and PRCC2 into separate bins with their attendant prognosis. So the message as far as the prognostic workup is concerned, in clear cell renal cell carcinoma, PAP1 indicates bad prognosis both for localized as well as for metastatic disease. TP53 means bad prognosis in metastatic disease. PBRM1 inactivation signifies good prognosis, at least in metastatic disease, but maybe also in the localized disease. In papillary renal cell carcinoma, the same phenotype, which can be confirmed by surrogate staining for P16 and fumarate hydratase, identifies a subset of papillary renal cell carcinoma with appalling prognosis, and expression of LET7 family of microRNA can separate papillary renal cell carcinoma 1 from papillary renal cell carcinoma 2 in a very tidy fashion. So the last part, that is the predictive role of biomarkers in metastatic clear cell renal cell carcinomas. And you will all know that there are about 12 drugs and combinations which can be used. And these drugs and combinations basically belong to VEGF pathway inhibitors or antibodies, ICI immune checkpoint inhibitors in combination with the VEGF inhibitors, or immune checkpoint inhibitors themselves in combination, and in subsequent line of therapy, immune checkpoint inhibitors by themselves alone, and mTOR inhibitors. But the problem is that all patients treated by one regimen don't benefit by that regimen. The challenge is to find one superior option amongst all therapeutic choices in one particular patient, and can molecular biomarkers help here? So let's look at the predictive role of biomarkers in VEGF targeted therapies in clear cell.
Mehta, you have last 5 minutes left. Can you sum up?
So I sum up. You want me to finish here? So here is okay. I just go through very rapidly. So first is this: those who respond well to VEGF targeted therapy, they are enriched in PBRM1 mutation, and that has been confirmed in emotion study. That has also been confirmed in record study. The record study also showed that those which have lysine demethylase 5C inactivation, they have a astounding, amazing, good response with sunitinib. It has also been shown that those who have high angiogenic signatures respond well to sunitinib, and that was confirmed in the subsequent phase 3 emotion study also. Looking for the mTOR, it has been seen that mTOR inhibitor, the benefit is better in those who have loss of expression of P10 compared to those who have intact P10. And as far as the immune checkpoint blockade is concerned, it has been shown that the immune checkpoint blockade, the responses are better in those who have PBRM mutation, both, and as well as the survival is superior in those who have PBRM1 mutations. This has been very amply shown in this diagram, where you can see in this dendrogram deep and profound responses in those who had PBRM1 inactivation. Let's leave these two. And it has also been shown that those patients who have a low angiogenic signature, they are best benefited by a combination of immune checkpoint inhibitor with VEGF blockade, while those who had a high T effector signatures are best treated with the ICI and VEGF blockade. And it has also been shown across several studies that patients who are expressing PDL1 show better response to ICI blockade compared to those who do not but the negative predictive value is low, and about 8 to 10% of the patient without PD-L1 expression also respond to immune checkpoint blockade. So I will leave this papillary renal cell carcinomas, and then of course there are two universal biomarker, predictive biomarker, the NTRK fusion and MSI. High tumors, about 2% of RCCs are MSI high, and you can use pembro for them. So to summarize here, the PBRM1 inactivation in clear cell renal cell carcinoma predicts improved progression-free survival with the VEGFR TKIs and immune checkpoint blockade. But unfortunately, there is no approval for immune checkpoint blockade monotherapy in first line. The response to VEGFR TKI is inversely related to presence of T effector cells and del9p23. Expression profiling has shown that patients with high angiogenic signatures have improved progression-free survival with VEGF TKIs. Those who have a high T effector signatures, they have an improved PFS with immune checkpoint blockade combined with VEGF targeted therapies. And those who have a low angiogenic signatures are also best treated with a combo of ICV with VEGF targeted therapies. The lysine demethylase 5C is a very strong predictive marker for a prolonged and sustained benefit from sunitinib. And about the MET alteration, the MET alterations are seen in 30 to 40% of papillary renal cell carcinoma. They have not been found actionable so far in renal cell carcinoma, unlike in non-small cell lung carcinoma. And from my clinical colleagues, my suggestion will be this may be a good time to start looking for at least PBRM1, BAP1, SADD2, lysine demethylase 5C, and TP53 mutations in clear cell renal cell carcinoma for the purpose of prognostication and therapy selection. But I must add a caveat here that none of the biomarker has been prospectively validated to recommend its use. The industry is ready, the NGS panels are available, the labs are ready, and it is now time for the physicians to find out how best and effectively they can use the biomarkers to improve diagnosis, prognosis, and therapy selection. So I will finish here. Thank you so much for your patience, and I'm open to answering any question that you may want to ask.
Excellent presentation, Dr. Anurag Mehta. You have really given a comprehensive talk on this. And I think there are various questions which have come up. And one of the question is whether you need to use NGS or you can use IHC as a regular marker, as a regular test in your clinic.
So you can use IHC. You can use IHC for SADD2. You can use IHC for BAP1. You can use IHC for PBRM1. But the IHCs are very fastidious. They're very difficult to standardize. And my preference will always be for NGS. You get neat, clean results with NGS. And therefore, I will think, and NGS, you can include a few more relevant genes for which the IHC is not available. And therefore, my vote will go for NGS, though IHC is available for several of the biomarkers that I have spoken.
Yeah. And another question, is there any specific subtype of RCC which is associated with the obesity and DM in any mutations?
Which is associated with?
Any mutations. Any mutations.
No, what mutation? Where?
Is there any specific subtype of renal cell carcinoma which is associated with the obesity and DM?
No, I'm not aware of any such mutation.
Yeah, even I also vouch on that. I'm not aware of any such specific marker which can distinguish.
But what I will like to add that there are mutations which result in increased uptake of fat by the renal cell carcinoma cells, because the renal cell carcinoma cells accumulate glycolipids, they subvert the metabolic pathway. So when they subvert the metabolic pathway, they actually utilize certain genes to push the lipids into their cytoplasm. But if you will ask me, is there any mutation in that metabolic pathway which is responsible? The metabolic pathway is predominantly used by the tumors which have PIK3CA, AKT, mTOR, and TSC mutations. Maybe one of them does that, but I can't put a finger on one particular gene which is responsible for association between obesity and RCC.
Can I ask one question? How much allele frequency do you consider in your NGS platform to be taken as positive or to be taken as a treatment sort of a thing?
So that's a very good question. Now, this is basically all boils down to mathematics. So you first have to really know what is the tumor fraction. So if you have a 35% tumor fraction, and if you are looking at a gene which is getting inactivated, which has to show biallelic inactivation, then or the loss of heterozygosity, then the percentage allele frequency of the significant gene will be virtually equal to or little higher than the tumor fraction. Higher it is than the tumor fraction, more significant it is. But if it is a monoallelic inactivation, it will be somewhere around 30% or 40% of the tumor fraction. So now this is a concept of cancer cell fractions versus the mutant allele fraction. I think one has to get into the mathematics of that. And if it is more than 0.75, it means that it is likely to be a biallelic inactivation.
Yeah.
So, ma'am, can we wrap up this and then we can request Dr. Amit to take it forward?
Yes, yes. Thank you, Dr. Mehta, for
Thank you so
a
much.
wonderful insight into this RCC which can be used. And I think I invite Dr. Senthil for the next talk. He is a very good speaker, and I think Dr. Senthil Rajappa, over to you.
Thanks so much. So can I share my screen? Thank you. Okay, for the thanks, Dr. Vineet, and thank you for asking me to speak on this topic, which is a decade of experience with TKI in first-line metastatic renal cell carcinoma. Now, for people who are listening, if you think I'm going to show you lots of data and try to dissect through it, certainly I'm not going to do that in 10 minutes. What I will do is to share a little bit of my thoughts, and more importantly, what the reality is. And I hope at the end of this talk, you're not left hanging like what is shown on this small cartoon that I have put up here. Now, this is how kidney cancer was.
Sir, we can't see your slides, Dr. Santan, sir. We can't see your slides.
See my slides.
Can someone unmute or mute the dog, please, also? Thank you.
I'm sharing the screen, Tarun. Can you, is it visible now? Is it visible?
No, Sethil, we are able to see your email, Gmail account.
Oh my goodness. Okay.
Yeah.
So open your PPT, sir.
Can you see it now?
No.
Okay, don't bother. Tarun, can you show me the slides that I sent you?
So can we share our screen, sir?
Yes, please
Shrubi,
go ahead.
can you show the, can you show the presentation, please, Shrubi?
Tarun, can you mute everybody, please? Extraneous noises.
Yes.
Yeah.
Great.
Yes.
Great. Okay, so let's move on to the next slide. So what I was trying to tell you is that I will not load you with a lot of data. What I will try to show you is some of my thoughts and what the reality is. Next slide, please. Yes, so this is how the NCCN guideline for kidney cancer in 2006 was. You see that there are hardly any options. All that you see is nephrectomy if possible. And then when they relapse, you have interleukin and interferon. Next slide, please. But then today we have loads of things that we can do for these patients. And this is a typical example of a patient that presents to all of our outpatients. A 42-year-old with kidney cancer, you see it clearly on that CT scan that I have put up there. Performance status 1, he clearly becomes IDMC intermediate risk because he has presented with metastasis. Those are some lung metastasis that you see on these CT scan cuts. Now, there is a plethora of treatments that are available, and the most important of them being the immuno-oncology based treatments, because we are talking about intermediate risk kidney cancer here. Next slide, please. Now, why is it that we are actually excited about this immuno-oncology era in kidney cancer? I think the most important reason is that finally we have been able to prove that a treatment can improve overall survival. Now, if you recollect the TKI era, whether it's Sutent, whether it's Otrient, or any of these drugs that you're talking about, there used to be an improvement in progression-free survival, but absolutely no improvement in the overall survival at all. And finally, immuno-oncology drugs in combination or in combination with a TKI finally has shown an overall survival benefit. Next slide, please. But that comes with a little bit of a doubt here and there. The most important area where we are not convinced of the efficacy of the immuno-oncology drugs is the good prognosis or the good risk renal cell carcinoma. Now, for the immuno-oncology drugs in combination, actually the outcome is a little inferior compared to sunitinib, while for the combination of axitinib and pembro, the PFS seems to be better, at least in the updated presentation, but the overall survival so far has not shown to be better. So that's one area where there's doubt regarding the activity, but you can argue that the axi-pembro, the primary endpoint, was not looking at this group of patients. We will discuss that a little later. Next slide, please. Yes. So when I talk to my patient, for example, that 42-year-old whom we discussed a little earlier, and I give my big lecture as if I'm a salesperson for the immuno-oncology drugs, the patient finally says, I'm very impressed with your counseling, Dr. Senthil, but at the end of the day, I don't think I have money to really afford this. So that's the difference between the real world, which is the world that all of us live in, and the ideal world where some of us on and off go in and come out. The next slide, please. And that's the reason why we are very, very happy with Santa and Banta. Now, Santa is sunitinib and Banta is none other than pazopanib, right? So why are we calling them Santa and Banta? Because we have grown up with them, we are very happy with them, and we really love them because they are the ones who have come to our rescue whenever we had patients with renal cell carcinoma. And for me, these have been practice-changing data, whether it's the compares which show that pazopanib was as good as sunitinib, but with better quality of life, or the Pisces data, which showed that patients, and more importantly, also physicians, prefer using Votrient compared to Sutent there. And it's also important to make sure that doctors or physicians' quality of life is also equally important and well preserved when you're treating your patients with advanced metastatic renal cell carcinoma. Next slide, please. Now, the other question that we have to ask ourselves is, in a resource constrained setting, is it okay to go ahead with a TKI in the first line? And for me, the answer is a yes and no. For somebody who can afford the IO-based drugs, I think that's the best thing to use. For somebody who can't, I think this data is a little revealing. Checkmate 214. Only 40% of patients in the EP-Nivo group went on to get a second-line drug compared to 54% with Sutent. Now, only 1 in 4 of those in the Sutent arm actually had an immuno-oncology drug. The same is the case with the Keynote 426. Again, only half of patients in the sunitinib arm ended up having an immuno-oncology drug, which improves your overall survival in the second-line setting. So just imagine if more patients took the immuno-oncology drug in the second line, would the overall survival benefit have been blunted or would it have been lesser? I think that's a point to ponder with. I'm not trying to cut down the benefits of an immuno-oncology drug in the first line setting, But for somebody in the resource constrained setting with patients who can't afford these expensive drugs, this is a slightly different way of thinking and approaching treatment for these patients. The overall survival benefit, as I mentioned earlier, is with the immuno-oncology drug. Next slide, please. This is progression-free survival with pazopanib in various studies, both in the real-world studies and the randomized controlled trials. You clearly see that the progression-free survival ranges from anywhere between about 8-9 months to about 12 months. That's been consistent over time. Next slide, please. And so is the overall survival with these drugs, where you have roughly an overall survival that ranges somewhere around 2 years. And that's exactly what you get in many of these randomized controlled trials that have been done, not only with Otrient, but also with Sutent. Next slide, please. Now, if you again divide these based on your risk groups, there's a clear separation between the risk groups for the favorable, intermediate, and the poor risk groups. The median overall survival for all these groups together being about 22.2 months. Next slide, please. And if you look at some of the retrospective analysis of data from the nivolumab second-line study, it looks like there may be some benefit for pazopanib in the first line compared to Sutent, but please remember that this is an unplanned post hoc survival analysis, and this has to be taken with a pinch of salt. But for somebody who wants to, split hairs over data, this might be something to say that pazopanib may be a slightly better drug, but I don't really want to cross compare and do a post hoc analysis to come to such conclusions. So interpret with caution. Next slide, please. So just to summarize, we now have more than a decade of experience with these TKIs. The benefit seems to be consistent and reproducible in the real world data. Single agent TKI still has a role in first line therapy, and that's typically for good risk patients, patients who don't have access, they can't afford the IO drugs, and those patients who have contraindications to the immuno-oncology drugs. It seems to be a very justifiable choice in resource constrained settings. And if I had to give you a pictorial summary of what it is, the next slide, please. For the mass, it's the TKI. For the class, it might be the IO drug. And that's how I would like to conclude my talk. Thanks so much, Dr. Vineet, and I hand it over back to the organizers.
Thanks, Dr. Sadil, for the nice summary of the first line treatment of the TKI. I think if there are no questions, and then I will invite Dr. Ravindran for the next talk. He is a consultant medical oncologist with a special interest in the genitourinary and geriatric oncology, and he is associate professor and deputy head and senior consultant division of medical oncology, National Cancer Center, Singapore.
Okay, thank you, Dr. Amit, and thank you for this invitation to speak here. Let me share my screen. Okay. I suppose you can see my screen?
Yes, we can see your screen.
Yeah, okay. So I'm actually going to just probably consolidate what Senthil had nicely presented earlier. So I'm a medical oncologist. That's a picture of the National Cancer Center. And this was actually a last minute invitation because there was another speaker from Canada who was supposed to get on and unfortunately couldn't. So I hope I'll do justice to the topic given to me. So I'll start with a case study, and it's about Mr. P. It's a 75-year-old gentleman who presented with sudden onset of hematuria. He was seen by urologists, did a CT thorax, abdomen, pelvis, found a large renal mass, multiple pulmonary mets. Subsequently, because he was symptomatic, he underwent a cytoreductive nephrectomy. In this era, I think with at present, what we have best data is from Carmina's study. Sometimes we need to really think very hard whether patients need a cytoreductive nephrectomy. But once they have symptoms, then often you may not have a choice. You can embolize to stop the bleed, but sometimes cytoreductive nephrectomy may make more sense. So the histopathology came back as a clear cell RCC, WHO grade 3, and he was favorable risk. Actually, no, he was intermediate risk, sorry. So because we were planning to offer him treatment, so it was intermediate risk. Now, what would you treat him with? So there are a few options. A, watch and wait. Is this reasonable? In some circumstances, yes. As you know, RCC is one of the few tumors where there is some immunogenic mechanism that drives the growth. And as such, we have anecdotal evidence, also some retrospective series that show that patients, once they've had a cytoreductive nephrectomy, if they have limited disease in the lung or lymph node, can actually experience a complete response. Or sometimes they may have very slow growing disease. So has watch and wait been shown in a clinical trial setting? The answer is yes as well. Brian Reaney had a study, phase 2, that actually shows that a proportion of patients can wait for a while, and some of them nearly up to a year before you initiate systemic therapy. Now, so this patient obviously has only disease burden in the lung with the kidney taken out, so it could be a sensible option. Number 2, pembroexitinib. I think earlier Senthil did mention Keynote 426. I'll go through briefly with you details about the study. And then there's sunitinib and pazopanib. These, as he mentioned, really long-term standards of care. Sunitinib has been around since 2007, pazopanib since 2009. So we're talking about more than a decade of experience. Of course, EP-Nivo came into the picture with Checkmate 214. So how would you treat him? I guess this, simply put, is the range of options that we have in this point in time. So let's delve into the guidelines. Earlier, Senthil very nicely showed a screenshot of the guidelines in 2006. I was surprised. He even had a copy of that, and it obviously very sparse, very few things back then. Even the sunitinib was not approved yet at that point in time. But now we have a whole slew of drugs that we can use. And I mentioned the whole bunch of them earlier as possible options for this particular patient. What I want to highlight here are a few things. Firstly, the most important step that we should all be doing when we see our kidney cancer patients is to risk stratify them. So currently we use the IMDC criteria. So the IMDC is a large database consortium that was started by Danny Heng. This was back in 2007. And he first published his risk stratification in 2009. At that time, I think they only had 6 centers. We were one of the early centers to join. And now we have, as a group, IMDC compiled about 12,000 cases and growing. So it's a large multi-center, multinational database where we've obviously looked at a lot of these patients and their characteristics and come up with the criteria to stratify them at various lines of treatment. So what we're looking at here is first-line treatment. So in terms of first-line treatment, there are many, many options. I've highlighted pazopanib and sunitinib because they still play an important role. I'm sure many of us easily find ourselves seduced to some extent by the wonderful data of the combination therapy. But I think, as Senthil has mentioned, and even in Singapore, we don't have fully reimbursed healthcare system. So patients have to pay out of pocket. And these drugs are very, very costly, specifically immunotherapy. So I do use a lot of single agent VEGF TKI in my practice. So I just want to highlight that it still plays a key role. Now, this is the ESMO guidelines. Again, you can see all the drugs that you saw in the NCCN guidelines. The only difference is tivozanib. So tivozanib has been approved in Europe. So it is here, it's available. I gather it's also very well tolerated amongst all the TKIs. Unfortunately, it's not approved in other parts of the world. So at some point, if you do get it, be an option to try it. So first-line therapies in metastatic RCC. So as I mentioned to you, those were all the drugs. So let's delve into the data. So where we are right now, especially with patients with intermediate and poor risk, the standard of care should actually be ipilimumab and nivolumab. And this was based on this study, and this is the most updated analysis presented at ASCO GU this year after a 40-month median follow-up. And as you can see here, It met its primary endpoint, which is overall survival. But the key thing here is that it is in reference to patients who are intermediate and poor risk. So not the favorable risk. So if you can just look at the table on my right here, clearly you can see at the 42-month follow-up, which was when this data was presented, there was still a significant survival benefit favoring the use of the combination IO versus sunitinib. 47 months for median survival versus 26 months. So nearly a 20-month difference. Hazard ratio was 0.66. But again, to highlight, it's specifically in reference to intermediate poor risk. PFS, also not surprising, favored the combination therapy at 42 months. Nearly a third of them were alive versus just 19% on the sunitinib arm. But for the favorable risk, that was not the case. So if you look here, while this drug definitely was efficacious for the combination Nivo-Ipi, it was not the case for favorable risk. In fact, sunitinib did better. So the hazard ratio was actually 1.22 with detriment to patients on the combination arm. So why is this so? You would think, immunotherapy would have been a no-brainer, would have, done extremely well and beaten sunitinib, but it was not the case. I will explain that in a short while. Next, I'll go to the other trial that most people quote nowadays, the Keynote 426, where patients were randomized to receive either pembrolizumab and axitinib combination versus sunitinib. And the first of these data was presented at ASCO GU last year. At that time, it was a 12-month follow-up. Already, there was a significant survival benefit. At that point in time, the hazard ratio was 0.5. At the most updated analysis presented by Liz Plimak at ASCO this year, just 2 months ago, it was still significant favoring the combination arm, but this time the hazard ratio had dropped to 0.68 with 8% additional survival. Now, PFS also favored the use of the combination therapy, hazard ratio of 0.71, and with a PFS of 15.4 months versus 11. So that was pretty much significant. Now, but when you look at the favorable risk group, when you risk stratify them and you drill down to the favorable risk group, again, something that is pretty much consistent with what we saw with the Checkmate 214 as well. There was no significant survival benefit. But one thing to note is that the number of events, even at 24 months, was just very few. It was 26 versus 24. So again, perhaps too early to rule out the fact that favorable risk patients may benefit from this therapy. But at present, it doesn't look like that. However, when you look at overall survival, objective response rate and complete responses, clearly there was a benefit for pembro-axitinib. But objective responses, yeah, 69 versus 50. But what I want to highlight here is 50% ORR for single agent VEGF-TKI is pretty much consistent with all the prior studies and tells you how active single agent VEGF-TKI is. So adding on the immunotherapy actually doesn't add very much more, although the CR rates were very impressive. So that's something to consider. Now, why do the VEGF-TKIs work very well in MRCC, specifically the favorable risk? So this was a secondary study from Emotion 151. So if you recall, this was a study that compared atezolizumab with bevacizumab versus sunitinib. So this study, however, initially was very promising, showed a progression-free survival benefit, but later on, there was no overall survival benefit. Even up to this date, there's no overall survival benefit. However, one interesting thing that came out was patients who are favorable risk actually have an angiogenesis gene signature. And this is the reason why sunitinib or pazopanib does really well in this group of patients compared to the intermediate poor risk. As you can see here on the left-hand side, only 57% have angiogenesis gene signature high. So if you look at the biomarkers for immunotherapy response like T effector gene signature or the PD-L1 expression, in the intermediate poor risk, there seems to be slightly higher occurrence or expression. So that may explain why the Ipi-Nivo did extremely well with intermediate poor risk and did poorly with the favorable risk. And similarly, you can see that kind of signal with the pembro-axitinib, but because axitinib is a VEGF-TKI, it is able to perhaps reverse some of that issues with just having a pure IO-IO combination. So this is probably the reason why VEGF-TKI single agents do extremely well in favorable risk metastatic RCC. Now, there are also safety considerations with IO. I'm not going to dig too deep into this. As you know, a proportion of patients will suffer from pan-itis or multiple organ involvement of immune-related adverse effects. This includes the nervous system, hypothyroid, hypothyroidism, which is the endocrine system, the heart, the GI tract, more commonly things like skin and the GI tract, but some of the others can be seen relatively commonly as well. So we must always keep this in mind, although the companies and many people will attest to the fact that the data actually shows these drugs are relatively safe, but cost being a big issue. So when we choose these drugs, as Senthil elegantly pointed out, there are a lot of factors we need to consider: efficacy, safety, tolerability, and cost. So pazopanib, as you know, is non-inferior sunitinib. So he mentioned this trial, COMPASS.
Hello,
Hello, can you hear me?
Ravindran, we can't hear you.
I'm sorry, can you hear me now?
Yeah.
Yeah, I apologize. So clearly you can see from this that patients prefer pazopanib. It didn't matter whether they started with pazopanib first or they were on sunitinib and went on to pazopanib, they still preferred pazopanib because there were far fewer toxicities with the drug, better quality of life, and hence the reason for the preference. So now we've gone through the trials, and I think one thing to realize is that trials are not reflective of what happens in the real world. So clearly trials incorporate patients who are fitter, who have obviously pristine blood profiles, and would, if for no other reason, be even fit enough to, run in the Olympics and stuff like that. So they're not reflective of the real world. They're not your 70, 75-year-old patient who has multiple comorbidities, some level of frailty. So what we really need to look at are real-world studies. So one such study is the principal study. So Manuela Schmedinger actually presented this and published this in The Oncologist last year. So this was a real-world prospective observational study of the use of pazopanib in MRCC patients. So patients were treatment naive, but a small proportion of them, about 5%, were cytokine pre-treated. So this was going quite far back. And the key inclusion criteria was that they needed to be on Votrient within 30 days before getting enrolled into the study. Primary endpoints, typical of any clinical trial, which was OS, PFS, objective responses. We also looked at AEs and other events that occurred. There were secondary endpoints as well, like clinical effectiveness and relative dose density that they looked up for. Now, these are the top-line results that were published, and clearly patients with favorable risk did extremely well, 25.4 months. This is comparable with the registration trials by Cora Sternberg, which is also about 22 months. So the data here actually showed that real-world patients did do as well as clinical trial patients. When you look at PFS, again, whether they also did very well as well when compared to historical references, including the registration trial, as I mentioned. So this was done mainly in the Caucasian Western population. So I led a study which is called Parachute, and it's very similar to Principal, and we have some of the data that should be out in publications by early next year, because we've just analyzed the final data, and again, the results were quite comparable to what we see in clinical trials. I'm not able to share that with you, but you'll be seeing it out soon. It will be presented at ESMO Asia as well this year. Now, in terms of safety, I think this is very consistent with your experiences in using the drugs. So I'm not going to belabor these points. Again, hypertension seemed to be a bit less than the phase 3 trial. The diarrhea seemed to be a bit less than the phase 3 trial. But I need you to take all of this with a pinch of salt. With any real world study, unfortunately, it is not so easy to capture the AEs compared to the clinical trials because there's more rigor put into clinical trials. They are seen more frequently. A lot of these questions are asked more rigorously compared to real world studies. So perhaps that may account for why many of these patients didn't report these symptoms, because a lot of times if you don't ask, they don't tell. So I think you need to consider this with a pinch of salt. But I think the key points were the efficacy results, and obviously that was comparable, and that's something really quite impressive, because very often real world data doesn't seem to be able to match clinical trial data in terms of effectiveness. So in summary, numerous treatment options are available. Biomarkers have not been established yet as a key determinant for treatment selection. Single agent VEGF TKI still play an important role in the first line treatment, specifically for favorable risk. But in most countries in Asia where we don't have reimbursement for immunotherapy, it is still the mainstay of care. And cost and patient preference will be major factors in determining choice and accessibility. So we should really think about value-based care. It's not about, throwing all the big guns, the kitchen sink upfront, and consuming resources that we can ill afford for benefit that may actually be marginal. So those are things to consider. Important to have cost-effective studies to see whether these drugs are actually worth using upfront. Some of these drugs, again, the combinations are not mature yet in terms of the duration of follow-up. So we still need to wait. While there may be some survival benefit showing now, if you follow up, maybe this may change in time to come. Clearly, the hazard ratios reflect that in Keynote 426, for example. So with that, I thank you very much.
Thanks, Dr. Ravindran, for nicely explaining the role of TKI currently. So I think there are no major questions in this. So then I will hand over the further proceeding to the organizers.
Thank you, Dr. Anuradha and Dr. Amit, for chairing this session. I would like to thank Dr. Mehta, Dr. Rajappa, and Dr. Ravindran for this, for giving us wonderful insight on the topics like biomarkers and RCC and roles of TKI. For the next session on lines of management and RCC, I would like to invite Dr. K. Pavitran and Dr. Sudeep Shrestha. Dr. K. Pavitran is professor and head at the Department of Medical Oncology, School of Medicine, Kochi. Dr. Sudeep Shrestha is founder and executive chairman, senior consultant and medical oncologist at Nepal Cancer Hospital and Research Center. Thank you, sir.
So the next talk is by Dr. Vineet. He is currently the Director of Medical Oncology at Rajiv Gandhi Cancer Institute, Delhi. He'll be talking on the first line treatment of metastatic renal cell carcinoma. What is the current status in 2020? Over to Dr. Vineet.
Sir, you would like to share your screen, Dr. Vineet, sir? Surabhi, can you just remove the screen? Yeah, Dr. Vineet, sir, you need to unmute, please. So we can see your screen.
Yeah, can you hear me?
Yeah. Yes,
yeah.
very well.
Yeah. So the topic which I'm going to discuss is the first line treatment for metastatic renal cell carcinoma in 2020. And the startup has been nicely alluded by Dr. Senthil and Dr. Kannavishram. And there would be a slight overlap, but then this they wouldn't have shown. So this is my favorite slide, in which you see a lady with this big scar mark here, which is going across the upper abdomen. Fortunately, this is healed, and she was diagnosed by us at Rajiv Gandhi as a case of metastatic RCC, but went on to a faith healer in Himachal Pradesh, in Kangra, where he put some vitriolic fluid, which he puts for all cancer patients, and they have blind faith. And she came back to us in toxic shock, and she was admitted in ICU. After 2 or 3 weeks, probably we were able to pull her out, and now she's doing good on treatment. So you have immunotherapy, you have targeted therapy, you have chemotherapies, and you have faith healers therapies also. So with that, what are the key factors in the management of metastatic RCC? One is obviously to prolong the life, albeit maintaining the quality of life if possible. And of course, along with that, there are regulatory issues, the drug availability, which is a big problem in India. And of course, in many of the countries, you have new drugs, but availability is an issue. So that can be a handicap. And of course, at the end of the day, finances also play a role. So if you look at the guidelines, you find that it is according to the risk stratification, which is initially it was the MSKCC stratification, and now it is the IMDC stratification, in which you have the favorable and you have the poor and the intermediate risk, which has been nicely alluded by Dr. Senthil earlier. So you have about 3 drugs, 3 combinations which are there in a favorable group, that is pazopanib, sunitinib, and then you have a combo now of IO, that is pembrolizumab plus axitinib. And in the poor risk, again, the drug of choice is ipilimumab, nivolumab. And of course, the same drug which is there in the favorable risk is again there. And cabozantinib has climbed up from second line to first line after the trials. So there is still a flux here, and definitely in times to come, you'll find that a lot of drugs will climb from the second line or third line to the first line, and vice versa. Some drugs may go out. So this is the IMDC scoring or the MSKCC scoring. There is another scoring which is coming into vogue in light of the fact that you have the immuno-oncology drugs. That is the Emery risk scoring system, which is predominantly on the number of the metastatic sites, the body mass index, and the MLR, which is the monocyte to lymphocyte ratio. And all these have scorings here, as you can see. And it is again divided into good, intermediate, poor, and very poor risk scoring, where you can see that very poor risk is 3 to 4, poor risk is 2, intermediate is 1, and good risk is 0. And accordingly, you have the survival. In the very poor risk, it's about 4 months, which was there in this study. And good risk, the median survival has not been reached. Suffice to say that this scoring using the MLR and the BMI, that is the body mass index, and the number of sites of METs may be an effective way to predict the survival in these patients of metastatic RCC in the immuno-oncology era. These results again have to be validated in a large prospective study. So I thought that it should be an eye-opener here that other risk scoring systems are also coming in vogue. So when you look at the treatment options as of now, you have small molecule tyrosine kinase inhibitors, and then you have a plethora of combinations, IO plus IO, that is immuno-oncology plus immuno-oncology drugs, or you have a immuno-oncology with a TKI combo, which I'm going to allude you. But when you look at the older TKIs, which were used initially, it was sunitinib, which was the champion, and then came pazopanib, and this was pitted against the earlier champion, which was interferon. So you had sunitinib, you had pazopanib, you had interferon plus bevacizumab, and then came axitinib. Sorafenib, which started earlier, slowly got relegated to the second line. And as early as March 2020, this Adonis trial was published, which showed a real-world experience with sunitinib in the treatment of patients of metastatic RCC, according to the risk score. And this also showed that the median progression-free survival was 10.4 months, and the OS was 34 months in first line in patients who were treated with sunitinib. And this also highlighted another point, that patients who had only one intermediate risk factor, the outcome was almost similar to those patients who had good risk scoring or zero risk scoring. And this was seen in another trial, which was the STARTOR registry, in which again the real world outcomes according to the MSKCC and IMDC were seen. And this again showed, when you see the overall survival in patients who had a 0 or 1 risk factors, it was almost the same vis-a-vis if it is compared to having more than 1 risk factor. So it plummets from 37 months or 30 months to about 18.5 months. So there was a difference, and this was seen across, whether it was the IMDC classification or it was the MSKCC classification. It was 37 months versus 19.9 months. So the behavior of patients who have only 1 risk factor and who are clubbed in an intermediate risk, there can be, a thought that these patients could still be managed with the small molecule tyrosine kinase inhibitors instead of the IO drugs. And of course, certain riders have to be there, which I'll allude to later. So according to the STARTOR registry trial, it was that overall survival for patients with 1 risk factor may align with the favorable risk group, and patients with 2 or more than 2 may align with the poor risk group. So there's another study which was with the TKI after TKI in a responding patients. So many a times we have seen earlier, say about 5 or 8 years earlier, when you had a patient on sunitinib and the patient was responding beautifully and the disease-free interval was about 2 years or more, and then the patient progressed, there were studies to say that yes, these patients will again respond with another TKI, and this was seen in the exitinib trial, in which patients progressed after first-line treatment with sunitinib. And this was again pitted against sorafenib. And here it was seen, if you just focus here, patients who had non-bulky disease, patients who had no bone or no liver mets, and they were in IMDC good, that is favorable, or intermediate with 1 poor prognostic factor. These were the ones who favored well, it did well with exitinib versus the trial drug. So this again is reiterating the fact that you can, if you want, use these drugs if the patient has only 1 factor, which is climbing the risk stratification to intermediate risks. So the patient in the favorable risk, exitinib significantly increased the overall survival with the survival probability of 68.7 months, even after progression on sunitinib. So if you see the risk, the toxicity profile, most of these drugs had rash, pyrexia, neutropenia, anemias. This has been alluded earlier also. So this had to be kept in mind. And even now when we give these drugs, we keep in mind about these side effects of these drugs. So when you synergize these drugs, that is combined with the immuno-oncology drugs, you find that it has a symbiotic relationship. How? That the elevated VEGF may inhibit the dendritic cell maturation and cause immunosuppression. And side by side, the VEGF inhibition may reduce the number of Tregs and tumor-invading myeloid-derived suppressor cells. So when this happens, the anti-VEG therapy may prime for a better effect than only a PD-1 or a PD-L1 therapy. And this was, when it was combined with exitinib, that is pembrolizumab was combined with exitinib. And we have 2 frontline trials, that is the Checkmate trial, in which 1 IO is with another CTL4 inhibitor. And again, you have Keynote 426, which is pembrolizumab plus exitinib, and which showed survival benefit. There are other trials, avalotinib plus exitinib versus sunitinib, and that showed that it had a progression-free survival benefit. OS is not matured as yet. Another one was the atezolizumab plus bevacizumab. Unfortunately, the overall survival was not there, and only PFS survival was there. So other drugs which are there, that is pembrolizumab plus lenvatinib, this again has been pitted against sunitinib, and a combination of nivolumab plus cabozantinib, and the results have not come now. So I'm going to discuss these two trials, that is nivo-ep versus sunitinib, and of course pembrolizumab plus axitinib versus sunitinib. So if we see the combination of IO and IO, that is nivolumab plus ipilimumab versus sunitinib in advanced RCC, this was adequately highlighted in the Checkmate 214 trial, which was a first-line phase 3 trial, and this was against the current standard, which was sunitinib. And we had the 42-month follow-up, which was presented as an abstract in GU ASCO, and that showed that in favorable risk groups, the survival benefit was not that significant as it was in the intermediate and poor risk group patients. So here you can see there is a stark difference between this drug and sunitinib, in which the survival has not reached in the nivo-ep arm, and it is much better than sunitinib. The other combination which was there, that is the IO plus VEGF combination, in which axitinib and pembrolizumab was pitted against sunitinib. So I've already alluded to you the rationale of combining an immuno-oncology drug with a VEGF, in which one potentiates the other vis-a-vis when one is given alone. So this was again a first-line phase 3 trial in which pembrolizumab plus axitinib were given against sunitinib in a 1:1 randomized fashion. And these were in treatment naive patients with metastatic clear cell RCC, and tumor tissue again was available for PD-L1 testing. The treatment was continued till unacceptable toxicity, and it had dual primary endpoints, that is overall survival and progression-free survival. And this was published in the NEJM in 2019. And here we see whether it is the favorable risk, in which you can see that there is a benefit, survival benefit, or it is the intermediate or the poor risk benefit. Unlike the ipi-nivo arm, you find that this definitely has an edge, and that is why in NCCN it was accredited as the drug of choice, in which level 1 approval was given, whether it was the favorable risk or the intermediate risk or poor risk. The criticism in the keynote 426 was that the CR rate has moved up to 8.8%, but 30% of patients have IMDC favorable risk disease in these patients. And favorable risk had 11% CR rate, which was more than the ones in the intermediate and poor risk group. And the progression was only 11.3% patients, which was attractive. And 94% of patients achieved some reduction in the target lesions as compared to 86% in sunitinib. So if you do a comparative assessment in both the ipi-nivo versus the pembro and the axi, you'll find that surprisingly in ipi-nivo arm, the curves, they start separating after 9 months, meaning thereby whether you give sunitinib or whether you give the ipi-nivo combination for the first 6 months, there is not much change in the response. Whereas if you see in pembro and axitinib versus sunitinib, you find that the curves, they separate much earlier, much prior to, as compared to the ipi-nivo arm. So this can be a point of concern when you give ipi-nivo versus sunitinib. And here, the questions which arise in our mind is that are we putting RCC patients at unnecessary risk if we are not offering upfront VEGF inhibition? And can we do something about the anti-CTLA4 component, because we know that most of the side effects are because of this and not because of the immuno-oncology drugs. And the third question would be, which is very logical, that can we use only a PD-L1 blocker? Now, VEGF TKIs have a role on the primary tumor, which has been shown in the earlier talks also. If we see the response of the primary renal cell carcinoma to the systemic therapy, this was published in the European Association of Urology. The study design in this was, to see the effect and characterize in phase 2 and phase 3 trials to study the upfront systemic effect of therapy on the primary tumor. And here you see that you have first line therapy. If you try to focus here, it's a busy slide, but if you just try to see first line therapy here, any therapy versus VEGF target therapy first line, you will find that about 17% of patients are responding here vis-a-vis 28% of patients. So when you give a VEGF inhibitor initially in the first line, you find that the response is much more than any other drug which is given in the first line in these patients. And again, when you see the intermediate and poor risk, this falls rapidly irrespective of whichever drug you give. So when you focus on the favorable group of patients, these are the ones who are going to benefit from the VEGF group of drugs. So the point to consider here was that study characterized the effect of systemic therapy on primary tumor as the upfront VEGF therapy leads to an ORR of the primary tumor of about 28%, supporting the palliative role. And this was comparable to all these studies, whether it was the Checkmate, the Compass, or the Carmina trial, which was there. And this found that the ORR in the primary tumor is associated with better OS compared to the ones non-responders, except in the poor risk group. So the other points to consider, when you give the first line, whether it is the IO or the IO plus TKI, the pros of IO and IO combination is that mature follow-up, durable responses are there, unmatched quality of life as compared to the TKIs, and there can be a potential to stop therapy. The cons again are that you have a higher immune adverse events rates, and they are unpredictable. You don't know when they might come or when they might not come. And again, as it has been alluded earlier, the initial responses may be good, but then if you see the overall response rates, they may still, not reach up to our expectations as of now. So can a biomarker help sway our decision on IO versus IO-TKI? Unfortunately, there are a lot of biomarkers which are there in the relevant studies, and Dr. Anurag Mehta has very nicely alluded to them. But at this point of time, you cannot say specifically, not even PDL1, not even tumor mutation burden, not even the NLR, that they will help in the issue of the choice of the first line. The next would be, can the morbidity profile sway the decision for first line? Morbidity, as you can see, as I've already told, in immunotherapy may never occur, and it is dose independent, but it can emerge anytime, and it needs treatment to resolve. Whereas in the VEG TKIs, it is almost guaranteed. You give the drug, you have the side effects, and it is dose dependent, and usually it emerges by about the 3rd or the 4th week, and then it might resolve at withholding the drugs. So you have both the pros and cons for immunotherapy drugs and the VEGF TKIs. Suffice to say that 60% of patients treated with the Nivo-EP required systemic corticosteroids for adverse events. And simultaneously, if you see the side effect profile, the adverse events in both the EP-Nivo group and the Keynote, that is the axitinib pembrolizumab group, you find that to a certain extent, there is side effects of the TKIs, which are taking the toll, as you see in this forest plot. So side effects definitely is a concern in these drugs. And the other issue again comes non-clear cell histologies. Well, we know that sunitinib or the TKIs, they work in clear cell histologies as well as the non-clear histologies. We have the data for that. And lately,
time is getting up.
Yeah, I'll just, and lately it has been seen that, the sarcomatoid group, this is the one which is preferred as far as the immuno-oncology drugs are concerned. Patient's preference, well, this was a trial which you see. And here again, the patients rank efficacy as the most important outcome when considering treatment option. Toxicity, time of therapy and cost are not the significant pretenses for the patients, and further data is warranted, whether it is a combination or whether it is giving alone. Long-term data again is not there for the immuno-oncology drugs. So when first-line treatment is there with the advanced RCC, what is the right choice? Well, this is my penultimate slide. Here, if you have multiple good systemic therapy options, no clear choices occur at this point of time. Good risk patients, those with favorable or intermediate risk, can have a survival of many years with or without therapy. Consider debulking nephrectomy, interval debulking nephrectomy wherever possible, or sometimes active surveillance can also be there in a very small cohort of groups. Patients who have IMDC, intermediate or poor risk disease, no significant autoimmune disease, no and they have contraindications for VEGF blockers. In this, you consider a combination of Ipi-Nivo, that is ipilimumab and nivolumab. Patients who are in IMDC favorable or intermediate risk with just one factor, or patients in intermediate or poor risk group who need rapid response, or a need to avoid the immune-related adverse events associated with dual IO therapy. In those, we can consider a combination of IO with a VEGF. These are the phase 3 trials which are on the radar, and the results have to come in for time. And of course, some of them will climb up, especially the combination with cabozantinib. Everybody is looking at that. So I think I'll stop here. I thank you for your patient hearing.
Thank you, Dr. Vineet, for the very nice presentation. I think questions, I think we are short of time.
I think we can take the question in the panel discussion because the time is, yeah. Thank you.
Good evening. Yeah, we have now second speaker, Dr. Ranjit Sahu. He's associate professor from Department of Medical Oncology, AIMS. So we'll be talking on second line treatment of metastatic RCC. Dr. Ranjit Sahu, please.
Yeah, thank you. Thank you for the kind introduction. So, am I audible?
Yes.
Am I audible?
Yes, you are audible. Your slides are there, Ranjit.
At the outside, I would like to thank the organizers to have given me this opportunity to speak about the second line management in RCC. I will restrict my talk to mainly the clear cell. Okay. So I do not have anything to disclose as conflict. And many of the slides I have taken from CCO. Okay, so just to pick the pace. The contrast between Dr. Talwar's talk and my talk, and you could see this is the latest version of NCCN guideline. When you see the first line therapy, it is pretty much clear. Okay, it is pretty clear. You divide the patients into risk, and those who are favorable, you treat them differently. Those who are poor, intermediate, you treat them differently. So it is pretty much clear in this scenario when it is first line. Now, when it comes to the subsequent lines, it is like there are many Me-Too options like cabozantinib, nivolumab, axitinib, lenvatinib plus everolimus. They are all category 1. There are many category 2B options like temsirolimus, sorafenib, bevacizumab. And there are many uncategorized options like Ipi-Nivo combination. Then there is axitinib, pembrolizumab, everolimus, pazopanib, sutent, and axitinib, avelumab. So there is more of this Me-Too options in second line clear cell histology. Now, if you, this is just to focus on what are the second line options. Now, these have been the pivotal randomized clinical trials in clear cell RCC post the first line TKI. As you could see, all of them, there are options like everolimus was better, with respect to PFS. Axitinib was better with respect to PFS. There was no OS benefit with either everolimus or axitinib. But when it comes to cabozantinib, when it is compared with everolimus, which was the existing standard, it was better as PFS as well as in OS. When you compare it with nivolumab versus everolimus, nivolumab is better in OS as well as in the overall response rate. Then there is this phase 2 data of lenvatinib everolimus versus everolimus. There was another arm of lenvatinib alone. So everolimus is inferior than lenvatinib, and all these two options are inferior than lenvatinib everolimus combination. So all of these are somewhat the standards as second lines. Now we need to find some rhythm into it. Okay. Yeah. Right. So the thing is, now at the second line time point, can we actually re-stratify these patients into good, intermediate, or poor? Actually, we can. If you use this IMDC classification in this second line, this is a publication in Lancet Oncology in 2015, and this is based on a population-based study. You could actually reciprocate all these findings when you classify them into favorable, intermediate, and poor risk. So it is still classifiable. The clear cell RCC, they are still classifiable into favorable, intermediate, and poor risk. You could look into more details in this study. Now, the thing is, when all these favorable, intermediate, and poor risk patients were treated upfront, what happens at second line? Now, you would be surprised to know 60% of these patients, that is clearly 2/3 of the patients, they retain their risk category which was there in the first line. Now, approximately 10% they have improved in the improvisation in the risk stratification, mainly from intermediate to favorable, mainly from poor to intermediate in 6%. In approximately 30% of patients, there is a deterioration. And it is 50% each from favorable to intermediate and 50% they deteriorate from intermediate risk stratification to poor risk stratification. Now, those who are favorable to start with, that is 85%. If you could see this thing, yeah. That is 85% of the favorable will remain as favorable. And when you look into, this is a retrospective data, and this was an old data when immunotherapy was not available. The only options which were there was either a VEGF inhibitor or an mTOR inhibitor at a time point, that is close to 6 or 7 years back. Now, when they looked into those patients who retained their favorable risk stratification even at the second line, it was found that the VEGF inhibitors, they fared better than mTOR inhibitors. But the situation changes when it becomes favorable to intermediate or favorable to intermediate risk. Here, in the retrospective analysis, you could see that mTOR inhibitors they are doing better than the VEGF inhibitors. So this is an interesting thing. So in clinical practice, when a patient is even favorable at the second line, when he progresses at the first line, there are two options. One is axitinib, as I have shown. This is a real-world STAC study, and those patients who respond well to sunitinib, they respond as well to axitinib. Now, there is another option which is not regarded in the NCCN guidelines, that those patients who are progressing while on, say, sunitinib, and they do not have any side effects, the progression is minimal, then you can actually escalate the dose of sunitinib, and you could retain those responses for another 6 months. So that is another option what you could try in your patients. Say if your patient had Sutent to start with, and he is somewhere around a reduced dose of Sutent, while progression, say 37.5 or 50 milligram in very different schedules, which is not 4/2, then you could actually escalate the dose of Sutent to a good effect in these patients. Now, the question comes, when these favorable patients, they change into intermediate intermediate risk stratification, how should you treat it? Especially those patients who have received sunitinib as a first line. Then this study, Meteor study, you could look into those patients who have gone into an intermediate risk stratification. Cabozantinib may be a better option as compared to everolimus. Now, Now the options have really increased. Now these days we have many options as first line. So if a patient has received first line as IO and VEGF inhibitor like pembrolizumab and axitinib, then actually the options which are there are relatively less, and they might not be that good options right now. Now this is a study about the uses of cabozantinib after first line after first line immune checkpoint inhibitors. If you look into this table, those patients who have received only immunotherapy and not VEGF inhibitors, they have found to respond better to cabozantinib than those patients who have received a combination of IO and VEGF inhibitor. So by giving a IO and VEGF inhibitor upfront, you might be compromising on the second line options, especially when you are using the VEGF inhibitor. So as of today, cabozantinib might be an option of as a second line post pembrolizumab axitinib, but you need to see that the time to failure rates are a lot less. It is close to 4.7. And in the non-immunotherapeutic era, when you look into the cabozantinib and everolimus study, it is as high as close to 8 months. Now, when you receive first line as only immunotherapy as a combination of IO VEGF inhibitors, then the responses are pretty much surprising. When you use a VEGF inhibitor post IO and IO, they are returning their responses. Like in the first study, if you see, it is mainly overburdened by the usage of Sutent or pazopanib. The overall response rate is 36% and PFS is 8 months, which is as good as using Sutent as first line. But when you look into the study like the third one, that is Judani et al., when it is post VEGF inhibitor and IO combination, the response rates are decreasing, as well as the time to failure of the PFS. It decreases to somewhere around 4.6 to 5 months. Now this is a forest plot. I have taken it from the cabozantinib and everolimus study. When you look at the favorable risk stratification at upfront or intermediate risk stratification at upfront, those patients have really benefited from usage of a VEGF inhibitor. But when it comes to the poor risk at second line or the poor risk to start with, then cabozantinib is not faring better than everolimus. Now, the thing is, this ipilimumab and nivolumab combination has revolutionized treatment in metastatic RCC, as would have been discussed by Dr. Talwar. Now, can we use them as a second line? Now, this is been presented in as an abstract outside. The response rates, even though it is not as close to the usage of first line, but it is pretty much close. So it remains as an option, but we need to look at the complete study. Now, the thing is, now a second line option, nivolumab is also approved as a second line option. Now, the question comes, if you initially try with nivolumab, can you, if the patient is not responding, can you salvage these patients by addition of ipilimumab? Actually, it is not a good idea to use ipilimumab at a later time point. So if you have to treat a patient as second line, let the data come completely. It should be ipi-nivo if the patient has not received immunotherapy upfront. Now, this is another interesting study of usage of pembrolizumab and lenvatinib, who after progression of previous therapy which is containing immunotherapeutic agent. Now, this is also pretty good. Now, when you look into the duration prior to the ICI, it is close to 7 months. And it is close to 60% those who have received either more than 1 or 2 lines of immunotherapeutic agent in past. Oh, I'm sorry. Right. So the overall response rate in this population who have prior immunotherapy, it is close to 55%, which is pretty good. And this is the overall response rate prior to usage of a PDL1 as well as an VEGF inhibitor, it is 59%. And this is the overall response rate after usage of both IO together, it is 47%. So these response rates are looking pretty good. We need to look at the longer follow-up period. So the take-home message is, those patients who receive the favorable risk stratification even at the starting of second line, that always means that these patients have a good response duration of Sutent, then axitinib is the choice. And till the patient becomes intermediate, you should think of adding something to it. Otherwise, you can well serve by usage of axitinib. If it is not favorable to favorable, it is any other combination, say from favorable to intermediate, you should think of other options like cabozantinib. Nivolumab, you have to wait for nivolumab and ipilimumab study, but possibly that is going to be an option in future. You can use a combination of lenvatinib and everolimus as second line if the patient is from favorable to intermediate. Now, for patients who are post IO and this VEGF TKI, those who are post double IO, then TKI is the best option there. There is no preference between Sutent is useful or pazopanib is useful in this scenario. Even you can think of axitinib or sorafenib even. So TKIs are well placed post IO therapy. And in future, we must be looking at a lot of studies using this pembrolizumab and lenvatinib combination. Now, for patients with IO and VEGF inhibitor, as of today, we have only cabozantinib, which appears better than the other options. But in future, possibly we are looking something like pembrolizumab and lenvatinib. Now, that was my last slide. I will be happy to answer a few questions if we have time. Thank you.
Thank you, Dr. Ranjit, for highlighting on the second line therapy of these complex issues, and many data are still to mature. We are still confused and waiting for more data to come to make it more clear. So with the interest of time, I think I should pass on this mic to the organizer. Mr. Tarun, can you take over?
So over to you, Dr. Shubham.
Okay.
Thanks a lot,
Thank
Dr. Putran and Dr. Shrestha. I also thank Dr. Talwar, Dr. Sahu for guiding us on medical management of metastatic renal carcinoma. Now, for last session, I would like to invite and request Dr. Naresh Somani and Dr. AFM Kamaluddin to chair the last session, and would be followed by a panel discussion. Dr. Naresh Somani is Senior Consultant Medical Oncologist at Bhagwan Mahavir Cancer Hospital and Research Center, Jaipur. And Dr. Kamaluddin is Assistant Professor in Department of Radiation Oncology at National Institute of ENT. He is Consultant Laboid Specialized Hospital and United Hospital, Bangladesh. He is also Scientific Secretary of Oncology Club, Bangladesh. Thank you. Over to Dr. Somani and Dr. Kamaluddin.
Dr. Kamaluddin, if you are there, you can start the proceedings.
So, can we ask our today's presenter, Dr. Manish Sinha, to start his presentation?
Yes, sir. Thank you very much. And I hope my slides are visible.
Yeah, they are visible.
They're visible.
We can hear you.
So my talk is on immuno-oncology, the role of immuno-oncology drugs in metastatic RCC, but I think the previous speakers have already dwelled on it. So I'll basically touch upon the previous data set, that is the Checkmate 025 study, which places immuno-oncology drug nivolumab in its right perspective as a second-line preferred option of treatment after exposure to TKI in the first line in the setting of metastatic RCC. So the presentation overview is about the renal cell carcinoma, the disease overview, the epidemiology, the unmet medical needs, and the treatment guidelines, and then dwelling on the Checkmate 025. And also, interestingly, the use of nivolumab or checkpoint inhibitors beyond progression, which this particular study looked at. So we know that approximately 90% of all kidney cancers are RCC, whereas the other tumors which are there in the kidney are transitional cell carcinomas, Wilms tumors, and sarcomas. And renal tumors have high level of tumor T cell infiltration, and we know that they have responsiveness to interleukin-2. And most of these kidney cancers are clear cell carcinomas. Non-clear cell constitute about 15% of them which are mainly papillary type or chromophobe type. The other is sarcomatoid, which is generally considered to have an aggressive variant and poor prognosis. The cell of origin for clear cell and papillary is the proximal tubules, whereas chromophobe and oncocytic carcinomas arise from the collecting ducts. We know that about 30% RCC patients present with metastasis up front, whereas about 20 to 30% of those who present with organ-confined cancers, they will develop metastasis and their survival is quite poor. As a matter of fact, of the 4 lakh new kidney cancer cases, about half of them or slightly less than half of them would die of their disease. So there is a significant need gap which is there. As far as the Globocon data is concerned, about 15,000 new cancer cases appear in India in every year, and of which more than half would die of their disease, and the 5-year prevalence is about 31,000. The incidence is not very high, but I think we are identifying more kidney cancers as we are as the diagnostic modality increases. So there is definitely an unmet need, and we need to improve survivals, and durable responses are required. And of course, these drugs have to be safe and tolerable, and we should be able to improve quality of life. So I think it is quite well known, even before the TKIs came in, we know that RCC used to be treated with interferon alpha or interleukin 2, and interleukin 2 was quite toxic and it was not very safe. And that is how immuno-oncology actually evolved in the spectrum of treatment of metastatic RCC. And the rationale is that a significant number of clear cell RCC patients have tumor cell positive for PD-L1. As a matter of fact, tumor infiltrating lymphocytes express high degree of PD-L1, which makes the RCC microenvironment quite responsive to immuno-oncology intervention. As far as subsequent therapy is concerned, after initial exposure to TKI, the preferred treatment options are cabozantinib or nivolumab, and nivo-EP is one of the treatment options, whereas other treatment options such as axitinib and axitinib plus pembrolizumab are also treatment options. Even the European Union also considers nivolumab and immuno-oncology options and cabozantinib as therapy options for those patients who are resistant to, or those who become resistant to VEGF based treatment. Coming to the Checkmate 025, so this was a randomized phase 3 trial, an open label study, which randomized patient in 1:1 to nivolumab and everolimus after they progressed on 1 to 2 prior lines of anti-angiogenic treatment and had a good performance status and no CNS metastasis and no prior treatment with either immuno-oncology drug or mTOR inhibitor. And they should not be on any glucocorticoids. So 821 odd patients were randomized, and the treatment was continued up till progression or unacceptable toxicity or withdrawal of consent. And the key eligibility criteria have already been alluded to. The primary endpoint was overall survival, whereas key secondary endpoints were objective response rate, progression-free survival, adverse events, quality of life, and overall survival by the PD-L1 expression. In the initial 12 months, every 8-week assessment was done, and thereafter 12 weekly assessments were done. Quality of life was measured, and tumor PD-L1 expression was checked for patients who had more than 100 evaluable tumor cells. As far as the characteristics are concerned, they are well balanced between the two groups, and about 72% of these patients had only 1 line of prior treatment, whereas about 28% had prior 2 lines of treatment. Coming to the primary endpoint, the overall survival was met. The primary endpoint was met, and it was statistically significant with a hazard ratio of 0.74. The median overall survival was 25.8 months as against 19.7 months with everolimus. And this was an unprecedented increase in median overall survival. The median overall survival at 2 years was 52%, and at 3 years it was 39%. And I think the curves remained well separated from each other at 3 years mark also. And the median overall survival was improved, irrespective of the PD-L1 expression, be it PD-L1 more than 1% or less than 1%, the median overall survival was improved. Also, irrespective of whether one or two prior lines of anti-angiogenic therapy was received by the patients, it was considered that there was improvement in overall survival still. Although those patients who were less heavily pre-treated, they fared better with nivolumab as compared to those who had received 2 prior lines of treatment. Overall response rates were much better, 26% versus 5%. And there were a few complete responses as well as partial response. Mostly it was partial responses. So more patients responded to nivolumab as compared to everolimus. Also, the median duration of response was 12.3 months, and ongoing responses was seen in about 17% patients of those who responded. That means of 106 patients, 25% patients who responded. Many of these patients had ongoing responses at the time of data cutoff. So these responses seemed to be quite durable as compared to everolimus, and as we can see over here that a few patients, more patients in nivolumab arm kept on responding to their to the drug as compared to everolimus. As far as risk stratification is concerned, be it a favorable risk group, the favorable risk group were also was improved with nivolumab as against everolimus. Intermediate and poor risk group also fared better with nivolumab as opposed to everolimus. Whether the primary the prior treatment was sunitinib or pazopanib, both treatments were in both the treatment arms. Nivolumab was better than everolimus, be it sunitinib or pazopanib. And also if the patient had shorter duration of response or months on prior lines of treatment, less than 6 months or more than 6 months, nivolumab stood the test of time and was deemed better than everolimus. Also, safety parameters. All in all, the safety parameters were better tolerated than everolimus. Nivolumab was better tolerated than everolimus, and there was no treatment-related tests which were recorded with everolimus. Mostly these toxicities were immune-related toxicities, and other toxicities were seen more commonly with everolimus as opposed to nivolumab. Quality of life was measured, and any improvement in the scores, that is higher scores, would indicate that there is better quality of life. And the scores of quality of life indexes were better with nivolumab as compared to everolimus, be it the EQ5D or EQ5D VAS score or utility score. Both the scores deemed nivolumab to have better quality of life as opposed to everolimus. To summarize this part of the discussion, the overall survival benefit with Opdita was consistent against all the subgroup, irrespective of the PDL1 status. 52% and 39% at 2 years and 3 years respectively were living on the nivolumab arm. The 3-year update, nivolumab continues to demonstrate continued to demonstrate durable responses, and nivolumab was also associated with better health-related quality of life indexes as against everolimus. Coming to the treatment beyond progression, patients who progressed, some of these patients continued to receive nivolumab beyond progression, and their overall duration of treatment was increased, 8.8 months versus 2.8 months, versus those patients who stopped IO drug at the time of progression. And also the post-progression, about the median duration of treatment was 3.4 months. And the reason for discontinuation was mainly progressive disease, that is second progression, and it was lesser of drug-related toxicities. The objective responses were more common. Patients treated beyond progression, the anti-tumor activity of the Opdita at the time of first progression, more number of patients had better responses who were continued beyond progressions. That means their primary response was better as compared to those patients who were not treated beyond progression. So more number of patients who were treated beyond progression had some response as compared to those who stopped treatment. Also, the performance status did not really dip in patients who were treated beyond progression, so they maintained their performance status. There was lack of deterioration in the performance status at the time of first progression. So that was perhaps the reason that they could continue beyond progression, because there were only radiological progression and not symptomatic progression in these patients. Coming to the results, about 48% patients showed further tumor reduction when they were treated beyond progression, and about 13% of these patients had more than 30% reduction in their tumor burden post-progression, as is evident in these waterfall plots. Also, the overall survival was increased when nivolumab was used post-progression, that is 20 months as against 12.2 months in patients not treated beyond progression. Also, the target lesion change post-progression based on the best overall response prior to the treatment beyond progression. So you can see that whether these patients had either a complete response at the before progressing before the first progression, or a stable disease or progressive disease. Almost about 30% patients to about 20% patients would have good responses even if they were to use nivolumab beyond progression. So of the patient with tumor measurement pre and post progression, about 28% patients with complete or partial remission, 6% patient with stable disease, and 14% patient with progressive disease as best overall response to first progression had a 30% reduction in tumor burden after being treated beyond progression. So based on their primary response to the treatment, I think one can conclude that irrespective whether there was a progressive disease, stable disease, or complete remission, if they maintained their quality of life and they were not deteriorating clinically, some of these patients, about 30% or patients, would have benefited by continued treatment with nivolumab, depending on whether their primary response was a complete or partial remission or stable or progressive disease. So there is definitely room for continued treatment with nivolumab if they were not deteriorating clinically. So, so the final conclusion is that the safety profile also favors nivolumab over everolimus, and the patients who were treated with Opdita beyond progression, approximately half had some reduction in tumor burden, and 14% patient had a more than 30% reduction in their tumor burden post-progression. The response rate with nivolumab stands at around 25%, and the 2-year overall survival is 52%, whereas 3-year overall survival is around 39%. With that, I thank you for your kind attention, and back to the organizers.
Thank you, Dr. Manish.
Thank you very much. Sorry.
Yeah, please.
So thanks, Dr. Manish. I think it was a long discussion. It was many long sessions, and we had many lights on this use of IO in this metastatic setup. And after TKI, definitely IO gave us some light, but I think still we have a unexplored area, that is the adjuvant high-risk group, which we don't have yet any solution. And hopefully in subsequent session, we'll be talking about those area. And definitely we are happy to have better overall survival and PFS, but we will be looking at more options and more combinations. And finally, I want to thank Dr. Vineet Talwar and the organizer for inviting me from Bangladesh. And we enjoyed the thing. It was enlightening. Thank you. Thank you very much.
I think Dr. Somani is there. Like Dr. Somani, your comments and questions, please. Dr. Somani, can you hear us? Okay. So over to you, Dr. Shubhra, please.
Yeah. Thank you, Dr. Manish and Dr. Kamaluddin, for updating us on role of immunotherapy in metastatic RCC. Now let's move for panel discussion. I request Dr. Amit Ratnan to moderate the panel discussion. Dr. Amit is consultant in Department of Medical Oncology, Manipal Hospital, Bengaluru. Excuse me. At the same time, I also request our panelists to put their mics and videos on for panel discussion. I would like to introduce our panelist, Dr. Amit Joshi, Professor, Department of Medical Oncology, Tata Memorial Hospital, Mumbai. Dr. Nikhil Gadial Patil, Director, Optimus Oncology Private Limited, Consultant Medical Oncologist, Yashoda Cancer Institute, Hyderabad. Dr. Sameer Khatri, Senior Medical Oncologist, Director, Shanti Mukund Hospital Cancer Center, Karkarduma, Delhi. Dr. Amitabh Singh, Consultant, Department of Genito Uro-Oncology, Rajiv Gandhi Cancer Institute and Research Center, Delhi. Dr. Ajit Beniyur, Senior Consultant, National Oncology Center, the Royal Hospital, Muscat, Sultanate of Oman. Dr. Anuradha Chople, Professor and Scientist in charge, Medical Oncology, Molecular Lab, Tata Memorial Hospital, Mumbai. Dr. Bharat Vaswani, Senior Consultant Medical Oncologist, Yashoda Hospital, Hyderabad. Thank you.
Good evening, everyone. I thank Dr. Vineet for giving me this role today. So we've heard some excellent talks throughout the last couple of hours, which have covered all the aspects of treatment of metastatic renal cell carcinoma. We've heard some good, excellent updates. What we'll try and do is just put in a few cases so that we can then discuss these cases and look at how we deal with them in the clinics. So let's start off with, this is our first patient. This is a 52-year-old male. He had history of left kidney renal cell carcinoma, for which he had undergone a left nephrectomy, and this is June 2015. He had a clear cell RCC with sarcomatoid features. Post this, he was not on any treatment, and then he presented with severe back pain in December 2015. And what we see was he had a large retroperitoneal mass in the left para-aortic region, which was involving the site of the prior nephrectomy. And he had multiple FDG nodular lesions in the surgical scar of the abdominal wall. So this was the kind of presentation he came with to us in December 2015, clearly metastatic disease. So I will start with Dr. Anuradha. Please, we've heard the whole discussion today, but could you just opine on the histological subtypes and especially about the sarcomatoid variant when we get this? How do we look at it?
Actually, I'm not a histopathologist. I'm a molecular biologist, so I don't think so.
Okay, I'm sorry. I'm very sorry. Okay, I have those molecular questions coming in next, but okay.
Yeah, sure. But I won't be able to talk authentically on this subtypes.
Definitely. Okay, I will ask my clinicians, because we eventually have to choose on this. And how do you go about choosing this? So Nikhil, how do you start looking at the histological subtypes?
So normally when a patient comes to us, we normally divide the patients into clear cell versus non-clear cell histology. And amongst non-clear cell histology, as we know, we normally don't go into too much of depth as such, but yes, we know for a reason that we know the papillary subtypes and so on and so forth, oncotypes, oncocytomas and chromophobes. But they are very rare subtypes as we normally see in the practice. Papillary, yes, we often see. And about the sarcomatoid, what the current patient in the discussion, that we often, I won't say often, but maybe around 5% of our cases do come across sarcomatoid types, and they're quite aggressive in terms of their behavior.
Right. So this is in clinics, this is where we stand and what Nikhil has said, and this is actually the division we do. We were always a little bit wary about sarcomatoid because they always used to be the high risk patients. But nowadays, when we see a little sarcomatoid, we are getting a little more excited because we know they're going to probably respond a little better. I will ask Dr. Sameer about how about the risk stratification? I would like to know what changes has happened in your practice in risk stratification between the earlier time and the present time.
So earlier, we were more based on the MSKCC, doing the LDH, calcium, and all those things. And now, more and more, it is based on this data consortium. And our stratification, as we know that the poor risk or intermediate or high risk, it is based on this. And it is very important to risk stratify. And based on the risk stratification, as we have seen in all the previous talks also, and we know from the data also, that those who are good risks, they have a very good chance of surviving for 5 years together. And those who have a poor risk, they have a very poor survival rate. So it's very important to stratify these patients according to this IMDC classification.
And Dr. Ajit, are you always doing this risk stratification in clinics? The reason I come to is many years ago, we were not really particular about doing it, because eventually we said, whatever the risk group, you're anyway going to give them sunitinib or pazopanib. And so we were never bothering to do it. Have
No,
you? Yeah.
Even previously we are doing it because the poor risk patients we are treating with everolimus. Actually, nowadays I don't bother too much about the risk classification because the combination of axitinib with pembro seems to be working pretty good across the risk groups. Although people prefer the nivo-ipi arm for the poor, intermediate and poor risk in first line. We use this axitinib pembro for all the three risk groups. So I really stopped bothering about risk groups nowadays.
Oh, okay. So that's kind of different. Bharat, what do you think?
Sir, what I think is everybody should do this stratification irrespective of what the treatment is given, mainly to prognosticate it. Whatever you give, what sir said is, if it is good risk, either of the two will give more than 5 years survival. But if it is low risk, if it is poor risk, whatever you use, the maximum survival was 47 months. So you can at least prognosticate your patient with whatever treatment you give. How will they do with whatever sort of treatment you will give? With a good risk, seems to do well with all the treatments available, and poor risk may do well with this combination, but overall will be lesser than what good risk people will live for. That is something that we have to remember.
Can I add something here?
Yes,
Can I add something here? Yeah. This risk stratification was basically meant for targeted therapy. And I think Dr. Vineet very nicely brought out that for immuno-oncology, probably you need to use the Emory classification, which has to be validated, of course. I don't think this, this particular IMDC risk stratification is good for immuno-oncology drugs.
Right. Amit, what about your comments on this?
Hello. Hello.
Yeah, Amit.
Are you asking from me? My name is Amitabh.
Okay. Okay.
So definitely we are using this risk stratification because we are not relying more on immunotherapy and this pembrolizumab or axitinib combination. We are more relying on sunitinib or pazopanib because of affordability issues. So definitely we are using this risk stratification to prognosticate the patient and just to decide whether we should go for the cytoreductive nephrectomy also.
Right. So I will be coming to you about that. Okay. So let me ask Dr. Anuradha now, because we had a wonderful talk initially about the new molecular classification. So where will we place this in clinics now?
Yes. I think if you talk, yeah.
Yes, Dr. Anuradha.
Yeah. Please go ahead with complete your question. I'm sorry.
Yeah. So I was wondering. So are we ready for trying to use this in clinics? And if so, like sir mentioned that NGS is all ready, should we be thinking about this for classification and then for treatment prognostication?
I think right now we are not into the classification, but we can definitely vouch on some significant biomarkers, like there is PBRM1, STAT2, BAP1, KDM5C, and there is also TSC1 and TSC2, which gives you the stratification for this treating the cancer patients.
Right. So do you think we should basically even for the classifications, like we're talking of the mid type, should we start doing those classification sets?
I think still there is no mature data on this. I think
right.
Over a period of time.
Amit,
sure.
I'm Anurag. Hello, Amit.
Yes, sir. Dr. Anurag, it will be nice to have your input, sir.
So,
yeah, sure.
I think 10 to 15% of RCC are not correctly diagnosed in the absence of the greater use of biomarkers or genomic IHC. I think we should start using genomic IHC for better classification of different types of RCC. As I alluded to you earlier, papillary RCCs, about 40% according to some studies, are not correctly diagnosed. And therefore, there is a great role, at least in diagnosis and prognosis, to use the molecular biomarkers or the surrogate IHC.
I think there are various 5 markers which are there, like IHC markers, which are HIF1 to ACD31, and VEGF1, which are also the prognostic markers. You can take it.
So my take will be that you should use them because Amit, more importantly, more significantly, there are 5% of RCC which are associated with inherited RCC syndromes, 5%, which is almost same as breast cancer and colorectal cancer. So in colorectal cancer, we go whole hog to identify the mutant kindred. Why shall we not go whole hog to identify the mutant kindred in cases of RCC? And for that, molecular testing is absolutely essential.
Yeah, for that matter, BRCA1 protein, which is very essential marker.
Right. I think this is a very important point that Vineet, sorry, Ajit, yeah, you wanted to say something?
Yeah, I wanted to say that I found Dr. Mehta's talk extremely fascinating and with a lot of take-home messages. In Oman, there is a lot of consanguineous marriages and we get a lot of these syndromes. I personally have 3 families with HLRCC, that is that hereditary leiomyomatosis with RCC. This is that fumarate hydrase, absence of deficiency of that. And this is the first time hearing that this bevacizumab with erlotinib is specific for that. So thank you so much for that, Dr. Mehta. Really fascinating talk.
Yeah,
so
I agree.
I also have 3 families of FH deficiency and 1 family of succinate dehydrogenase B deficiency. And because we have been using them, we have been able to at least, identify 4 such families.
Right.
Yeah, I fully agree with you. We should do more genomics.
So this was a very
Yeah, I have one question for Dr. Anurag. So what are the IHC markers which are proceeded upfront? Like, do the markers which I mentioned are done regularly? Like HIF1, R2, alpha, and PD?
So we use fumarate hydratase, we use succinate dehydrogenase, and we are in the process of using SAT-D2, BAP1, and PDR.
Okay, PDR. Okay.
Right. So I think this was very, very informative, and this is something we should all be now learning about and moving so that we can move our patients' treatment to the next level. And understanding this has been very important. So let's move forward for our discussion. This was our patient, and so we started him on sunitinib on December, and in April 2016 he came with increasing back pain, and there was we did a PET scan and there was large mass in the retroperitoneum. There were multiple lesions progressing. He had multiple liver lesions, bone vertebral lesions, lymph node metastasis, ascites, pleural effusion, and this patient was deteriorating very rapidly. He actually ended up going to ICU with sepsis, being on CRRT with all these complications during progression. So this is how his PET was in April 2016. So I would like to go to Dr. Amit Joshi now. How would you choose treatment for this kind of a patient? What are your factors you're choosing post progression on first line TKIs?
I think it's a little bit tricky situation clinically because patient has progressed over the sunitinib, and using the second line immunotherapy in a patient who is progressing very rapidly, I will little bit hesitant using the immunotherapy in this patient immediately. So either I will go for a combination of this thing, nivolumab with axitinib, because using only nivolumab in this patient might not be able to see that day. So I will prefer definitely a combination of TKI plus IO. Which TKI and which IO, that is a matter of debate. Firstly, we have used in few patients the nivolumab and then axitinib for 2 or 3 months to stabilize the disease, and then by the time the immuno takes over. So that we have done in practice, but there is no one answer whether the IO or a TKI will be better for you.
Right. So you would prefer an IO and TKI because it's a rapid progression. You want response. What about you, Nikhil? What do you think you would this patient who has rapid progression on Sutent in 4 months?
So if we are talking about this again, sarcomatoid type of RCC, who has not done well with the first line sunitinib, which is expected to happen because we don't expect them to even to hold on to the response for more than 5 to 6 months anyways. There has been more and more data, more in the first line as of now for IO, not too much, of course, and there are some case reports in the second line as of now. But probably I would have preferred this patient with maybe IO as of now as a single one rather than a combination, for the very reason there has been now a lot of suggestion of high PD-L1 expression with a sarcomatoid RCC, and that seems to be a kind of a driving force for this subset of patients. And the response is also quite high. In fact, if you look at certain studies, the response, the CR rates almost stand in the range of 18 or 15 or 18%. So I still like to believe that this patient might do well with the IO single agent. I'm not too sure whether I would be giving this patient a combination of IO plus TKI.
Right. Okay. So you would favor a IO agent and considering the sarcomatoid responses. I think that's a very valid point.
If there is availability of IO plus IO, I think that will be the best. If we have a ipilimumab plus, then it may be a best choice, a combination of IO plus IO.
Right. Oh, correct.
Sir, I can add one point. At the present, the best data is with IO and a long-term data also with a sarcomatoid type. What we know about sarcomatoid is these are immunologically driven tumors with a very high response rate of IOR, close to 60%, 18% CR with a survival of 30 months, 31 months. If you look into the checkmate study 214 study. So if given a first line, nowadays people, if given a choice, IO will be probably the first line because we have a data available with it with a good response, high CR and a good overall survival.
Right.
But do we have a data for the second line IO?
So you're correct there.
Only data is a phase 2 study of IO in those who have failed single agent nivolumab.
So
in
actually,
that Titan RCC study.
Yeah, Dr. Samir is correct in the sense that the data which was coming out is first line IO. But what happened was, because of the way the responses were, there is a lot of extrapolation, and even the guidelines are approving it as a second line therapy.
Yeah, definitely.
Second line. So it's there.
My choice will be IO nivolumab, and based on the checkmate 025 study.
Let me put this to you, Dr. Samir. If there was not a sarcomatoid pattern in this, would your opinion differ?
No, it will be same. Based on the checkmate study, I would like to reclassify also the risk stratification. This is again a poor risk stratification. And as Ranjit was also telling, it was a nice study. And this is a poor risk. And in checkmate study also, that those patients who had a poor risk, they did better.
Right. So I think everyone sort of leans towards an IO in this. Dr. Ajit, could I ask you, do you do any form of testing of PD-L1 in any of your RCC patients?
We don't do PD-L1. In fact, RCC is quite peculiar that they have very low tumor mutation burden, but they still respond very well to immunotherapy. Regarding the previous case, you're asking for the evidence. I can tell you this sort of patient would never be enrolled in a clinical trial, so you will not get any evidence. It depends on the expertise of the doctor treating to translate whatever evidence is there to real world data. Yeah, right. So in answer to your question, we don't do PD-L1 testing.
Yeah. So that's been one thing about though PD-L1 positivity, we know they respond better, but even we know the negative ones respond. So there's really no benefit of doing a PD-L1 in clinical practice. We've already seen the checkmate data already shown to us. So for us, this is 2016, mark you. Nivolumab was not launched in India. It came in somewhere in the end of 2016 in India. This patient was very, very committed. His wife was she said, I would try everything to try to save him his young age. And that year was when nivolumab was first launched in India. So we imported the drug, launched in the FDA approved in the world. And so this patient was so committed, she pushed us to import nivolumab, and we gave him 3 doses of nivolumab every 2 weeks. And we were amazed to see the response. And this is our first experience. And this is what got us into the fascination of immunotherapy in RCC. In just 3 doses, we repeated a PET, and we saw that it had completely disappeared and the PET had become negative. It is almost like treating a lymphoma. So this is really very exciting. My question let me start with Nikhil again. If your patient responds well, how long do you treat in clinical practice? Now, one part is the finance part. Yes, we understand this, but if finances were not an issue, or maybe how do you look at it?
So I would like to give as long as possible. as long as the patient is doing well. There can be a suggestion that at times we can stop because of the toxicity or for whatever reason. We already mentioned about finances is not an issue in this case, but if the patient is kind of achieving CR for quite a long time, when I say long time, maybe I can put as a ballpark figure of 1 year or something, then I may start thinking whether I can, kind of start reducing the dose or something, and eventually can stop in some patients, if not all. But if you really ask me what I can do, I think as long as possible, I will try to push it as long as side effects are at bay.
Okay. Dr. Amit Joshi, what do you do? Do you, in responding patients, duration of treatment?
Yeah, I think I partly agree with Nikhil that in patients who achieve a CR after that, definitely we will like to discuss, and if the CR maintained for a 6 month or 1 year, definitely we will like to discuss that we will stop this therapy for the time being and we'll watch closely. So otherwise, in patients who have a very good PR, I think after 2 years, there is some indirect data that if the patient even having a good PR, maintaining after 2 years, at least in first line, you can stop the. So I think 2 years in a patient who is responding well, and those patients who achieve a CR a 6 month or 1 year, that an individual call has to be taken for that.
Right. And Dr. Sameer, do you have patients who you have stopped treatment after response and are doing well, or what is your experience?
Exactly. I have not been so lucky. So I had started on 3 or 4 patients and they progressed after 8 to 10 months. So there was no opportunity for stopping treatment.
Okay. Okay. Dr. Bharat, your opinion on duration of treatment?
Sir, duration of treatment there clearly. If the patient has not gone in CR, patient is responding 2 years is what we can give, because we have data to suggest that if you stop at 2 years, they still continue to do well. Now, those patients who attain a CR, actually a controversial thing, initially we used to give it for 6 months post CR. That was what we used to, but somehow that 6 months is gone now and we continue to give as long as 1 year. So 2 years if the patient is responding and not in CR, and if the patient is in CR, 6 to 12 months, sir, we give it.
Okay.
Second line, sir, we have data, but not 2 years, nobody. What sir said, I had 2 patients who did well for 8 to 10 months, sir, and then they progressed. So nobody was lucky to go beyond those times.
Okay. Dr. Ajit, your experiences in second line therapy?
You're asking the wrong person. We get free treatment here, so
That's
they don't stop treatment ever. So long as they are responding. I think I have a patient on some 60th cycle of nivolumab or something. So
I did think that. Right. So our patient, we've actually treated this patient for 1 year duration, that is 18 doses, and we actually did PETs very frequently, every 3 months, then 6 months, and in June 2017 we had finished a year and we are seeing no sign of progression, so we discussed with the patient and decided to stop treatment. And the amazing thing is, even the last PET in Jan 2020, the patient is in complete remission, leading a normal quality of life. I would kind of push in my experience a little bit here is, we have now, I have 5 patients now whom I have stopped treatment in 1 year. And this 1 year also is after tapering off after 6 months after getting response. We've kind of give them 18 doses, then we stop, and there are at least 3 of them have crossed 3 years. So I think that stability of response, which Bharat has mentioned at 2 years, probably even at 1 year, I would be hoping that would last at 1 year and we can probably stop. Again, this is all financial decisions and we have to discuss this with our patients.
One of the options would be to increase the frequency of, reduce the frequency of infusions. Give it every monthly, or maybe give it every 2 monthly.
I agree. And I would kind of be tempted to do that with the same dose. We don't increase the dose. Yeah.
Right, exactly.
So moving on to our second case, this is a 63-year-old female presented with bone pains in December 2018. We had a kidney mass and we had nodes all over. We had small lung nodules, largest was 1.5 centimeter. And the biopsy of the lesion showed clear cell carcinoma. So this was IMDMC intermediate risk. So let me start with Dr. Amitabh here. This is our PET scan image here, and the patient clearly has stage 4 disease. Dr. Amitabh, yes. I would now ask you, what is the rule of...
So there are so many Dr. Amit in the panel.
Yeah, I know. That's why now I'm trying to clarify.
The voice is not clear. There is a...
So definitely, this patient has a fluid metastasis in the bone, lymph node, pulmonary metastasis. So this patient is not a candidate for cytoreductive nephrectomy. So just after getting biopsy, I would refer this patient for the systemic therapy.
So I will want your take on the Carmina trial as a uro-oncologist, and probably I'll take one take from the medical oncology side also.
So if you'll talk about the Carmina trial, so most of the uro-oncologists, they get offended after hearing the name of Carmina. We can talk for the night because there are so many flaws in the trial. But yeah, it's true that this is the only phase 3 randomized multi-center trial which has shown that sunitinib is better than nephrectomy upfront in especially in intermediate and poor risk disease. So the main key is the patient selection. If you are choosing your patient very carefully, then definitely you can go for the upfront cytoreductive nephrectomy, but your patient should have a very good PS, and you can achieve up to 90% of cytoreduction, and there should not be any visceral metastasis in the liver, brain, and there should not be florid bony metastasis. So these are the various markers like very good albumin level, PS level. So depending on all these factors, you can decide carefully that this patient is fit for the cytoreductive nephrectomy or not.
Right. So your criteria are patient fit patients, and more than probably 90% you should be able to remove.
Definitely.
Yes. So a quick opinion from one of the medical oncologists for this trial. Has it changed anything in clinical practice for you, Dr. Amit Joshi?
Yes, I think it make our life more easy in joint clinics. So previously, when we used to discuss, there was not too much data regarding the. So now we are at least clear that in good risk you can go ahead. In poor risk there is no benefit, and then intermediate risk you can take a decision as per the condition of the patient. If it is fit, then you can consider. And if the patient is not fit or having more than one risk factor which is putting into the intermediate risk, then definitely. So I think the good thing is that good risk you can go ahead. In poor risk there is not much benefit. Intermediate you have to individualize the treatment.
Yes.
Can I ask Dr. Amitabh, if
yes,
the patient responds very well to treatment, would you consider taking him up for surgery at that time, delayed nephrectomy?
Yeah, definitely, sir. Now our focus is mainly shifting to the interval cytoreduction nephrectomy. So if patient comes with florid metastasis, we definitely send the patient for systemic therapy. Then we reassess again after 2 or 3 months after getting systemic therapy. Now, if patient has responded very beautifully, then definitely we take patient for interval cytoreductive nephrectomy.
Thank you.
So I think what Dr. Amitabh has said and what Dr. Amit has said, both points are very valid and clear. What we should be clear about is it should not be interpreted saying that no one should undergo cytoreductive nephrectomy in metastatic setting. It should be clearly those who are clearly operable with minimal metastatic disease and fit patients should undergo cytoreductive nephrectomy first. It's not a trial saying don't do it. It's a trial saying time it better, but considers doing it also.
Yeah,
so moving on to this patient of IMDC intermediate risk in our setting, Dr. Samir, what would be your choice for this patient now?
This is an intermediate risk. So if the patient can afford, then IO plus axitinib, and if the patient cannot, then sunitinib or pazopanib.
Right. Nikhil?
I think I agree with whatever Dr. Samir had just now mentioned. For intermediate and poor risk patient, I think these are the two options with us, IO versus IO TKI. And both options are feasible. We don't have right now Yervoy with us, so probably pembrolizumab is a more appropriate choice here. I just want to add 2 cents to whatever we had discussed about Carmina. Just wanted to, if I am allowed to, Amit.
Yes.
Just that I agree with Amitabh for quite because he's in minority. So just wanted to give him the support here. That study has not lost more about lack of equipoise, more sick patients or more T3, T4 in the nephrectomy arm. So as of now, we are not 100% convinced about, at least I am not 100% convinced as of now from the Carmina or for that matter Certime that it has given us the conclusive definitive answer as of now. But that is the data which is available. You have to take it and you have to move on.
Right. I think discussing and choosing the right patient is what we have learned from there. That's probably the take-home message we have. So this was discussed anyway. So this was our patient. We treated with the immunoaxetinib combination, and in 2 months we got an excellent response, and we could see that the PET scan is clearly showing a very good response. We had a streak of patients, about I think around 4 or 5 patients in succession who got into almost near CR and really good responses. We became very excited that we are really hitting the thing and doing really well for our patients with RCC metastatic, with immuno and with immuno TKI combinations. So this patient was one of those who did really well, and so this was 2 months down the line. And unfortunately, so I think Ajit asked this question already to Dr. Amitabh. My question was to him was that only. At 9 months, he was doing very well. How do you time doing surgery? Which is the best time to do surgery in such patients? In 3 months, 6 months, anytime you get a good response, you would just go ahead and do the nephrectomy?
So our protocol is just to review the patient at 2 or 3 months, because those patients who start responding to the systemic therapy, they show very good response within 2 or 3 months. Their PS improves, their general condition improves, the systemic disease start responding very beautifully. Although we haven't seen very good response at the primary site, and I would like to add some experience of our center. So in interval cytoreductive nephrectomy, we have seen that although the nephrectomy is more difficult as per surgeon's perspective, because we have seen a colon is adherent to the kidney and we need to resect the colon along with the kidney also. We need to remove the spleen also along with the kidney. And this is well-known phenomena. After getting systemic therapy, especially VEGFR like sunitinib or pazopanib, when you go for the cytoreductive nephrectomy, then there are high chances that you will land up removing the adjacent organ along with the kidney also, just because of the dense adhesion between the kidney and surrounding structures. But although in the post-op, we haven't seen any significant difference in the recovery of the patient. We haven't seen very gross, major wound-related issues or recovery-related issues after getting 2 or 3 months of systemic therapy.
So do you think it will be the same with the IO new anterior therapy? So the reason I'm telling you is we've done a few patients now, and they were all PAT CR. So the question came and they asked us, why did you do it? So it becomes very interesting. Then do you think it will be the same, the difficulty in surgery which you're talking about?
From our experience, sir, we don't have very good experience with the IO, especially as Dr. Samir has said that we gave nivolumab combination in a second line therapy, but we haven't seen very good progression-free survival or disease response. So I can't comment on this. So if you say we haven't did any nephrectomy in IO patients, we did nephrectomy after getting sunitinib or pazopanib only.
Right. I think soon we will be seeing more and more of this group of patients, and it's very interesting. It's very, very, very exciting to see PAT CR when you see the specimen completely removed, and you kind of become very happy about it. So anyway, we were very happy about this patient, but very disappointing. After achieving near CR in the PET scan, in 9 months he suddenly progressed, and it was an extensive progression in the bones, in the lungs, pleural effusion. So what do you think of this patient who's been on IO TKI? Dr. Amit Joshi, I'll start with you. What would you do in such a patient in clinical practice?
So patient progressing after the IO plus TKI.
Yes. After a good response.
Yeah. So I think with the available drugs and the data, I think if it is progressing, then I think we will shift to the. There is no one answer, but what is available currently in India, then axitinib may be one of the options. If cabozantinib is available, then I think I will prefer the cabozantinib in this case. The other option, which is theoretical, which is not the phase 3 data, is the lenvatinib plus pembrolizumab. That has shown some good benefit in patient who progressed over IO plus TKI. So with the current available drug, I think axitinib is the choice. Next is the cabozantinib, it is available. And if patient is affording, then len plus pembro is another option.
Right. Ajit, what do you do? Because you must be having this group of patients.
We use cabozantinib. I was just curious, if patients actually go into pathological CR, wouldn't it be better to do a partial nephrectomy than do a complete radical nephrectomy?
We wouldn't know it was going to happen.
Can do a frozen section and see. Because I have not seen PATs here. It is. I mean, I'm impressed that you actually had PATs here.
Can I add one comment? Can I add?
Yes.
So actually, like in Delhi, so at RML, So Dr. Sood, he has some experience like doing nephrectomy after IO. So he found necrosis, only necrosis in the affected area.
That's exactly what we
IO. But we don't have any experience like that.
Right. No, we have seen it. So that's why we now know it can happen. Yes, Ajit, how would you treat the patient? You have experience in this group of people.
Yeah, we prefer cabozantinib, but I saw the data with lenvatinib pembrolizumab. Like the doctor mentioned, if phase 3 data comes, probably that would be a better option than just single agent cabozantinib.
Right. Okay. Bharat, what do you do in
Sir,
such group of patients?
Sir, literature-wise, what we are doing now, if available cabozantinib, we have to give some other VEGF TKI. We don't have cabozantinib here, so we have to choose for some other VEGF TKI. Actually, I have seen few patients who have done quite well on everolimus plus lenvatinib. I had two patients, sir, who had progressed on immunotherapy and I have developed CR, complete response on this combination. Two patients now who have developed complete response and are treatment for the last 10 months now.
Yes,
so something that people might not have tried, but I have now. So I'm comfortable with 5 mg everolimus and 18 mg lenvatinib. People quite do well. There is a synergism, sir, with this combination. And if you see the PFS 15 months in a second line, amazing. 25 months, although not statistically significant. And these people do quite well, sir. If the patient is fit, I tried that one, sir.
I agree with you. Dr. Bharat, I agree with you fully. This is our go-to regime for all our patients who receive IO-TKI. Because what happens is they've been exposed to axitinib, they've been exposed to IO. Lenvatinib, everolimus is a very potent combination. So we have a series of about 10, 12 patients now and extremely good responses. So when IO fails, when IO alone is given, we still have options with the TKI. But when IO-TKI fails, for me, the go-to regime is lenvatinib, everolimus, because both is available to us. Cabozantinib is not available in India. So for us, that experience is very, very minimal. So this is what we actually did for our patient.
That's an excellent idea. I think I should take it back with me. Excellent. Yeah, I'll try that.
Yes, it's a very good combination.
And they work amazingly well, sir. That is something we have.
I agree with you fully. We have patients who, as you said, got completely good response when IO-TKI failed. So we were very happy about that combination.
We have used everolimus in breast 10 milligram. And firstly, our experience is not very good. But your idea of using 5 milligram, maybe that's a good option. You can try that.
So the trial did 18 and 5. That was the trial data.
5 and 18.
What I do is 14 and 5 because 18 I've had issues. So I keep 14-5 as my standard. And I think lenvatinib is the main drug there. It's a very potent VEGF TKI. So that's why it works. So I think quickly we are coming to the end of this. So just quickly, I will present the third case just because of the uniqueness of the presentation. 60-year-old male, breathlessness, severe breathlessness on February 2020.
We have 5 minutes.
Okay, perfect. We quickly wrap it up with this. So I just wanted to show one patient. This is the presentation. You see the lungs, and this patient is oxygen dependent, severely breathless, not able to lie down flat in the bed. Extremely symptomatic patient, and clear cell RCC. What would be your choice here? Nikhil, what would you go for?
So we are looking at responses in this patient, that too very quick ones. I would probably prefer in this patient maybe a TKI with an IO combination.
Yeah, correct. I agree with that. This is some place where we require excellent and quick response. And though IO may be an option, I don't know. Our experience is not there much with EP because it's not available. So IO TKI becomes our choice in this. I just wanted to show this is 2 months of IO TKI. An excellent response. He's off oxygen. He's completely normal. He's able to do all his activities. So I personally believe IO is changing the life of our patients of RCCs. And depending on what type of combination, we need to discuss this in a lot of detail about the pros and cons. I personally believe getting a CR probably is one of the best things we can achieve in a metastatic disease. And if we could stop therapy, that's one of the most wonderful things in a metastatic RCC. This is something we have never done. But in the last 3 years, we have a group of patients in metastatic RCC. We have stopped treatment and are just observing them, with the longest follow-up being 4 years. So that's something we are seeing very encouraging in our patients. So I would like to conclude with this. I thank all the panelists. It was a very enlightening discussion and a very informative decision for me, learning about all experience from all over the country and also the world. So thank you, everyone. Thank you very much.
Thank you very much.
Thank you, sir. Excellent, sir.
Can I give a quick comment on this? Like,
yes, Dr. Anuradha.
Yeah, I feel that more and more of NGS data should be procured from this, because if there is an mTOR mutations, I think they better response to the and if there are some PDRM1 and BAP1, they have adverse effects. So I think this panel for this, like to have a broader spectrum for
Right.
this treatment,
That is
especially the
very
mTOR mutation, mTOR mutations.
So,
Like.
Yeah, I would like to add here, madam, the papillary variants,
Yeah.
you are rightly saying there are studies that they benefit more from mTOR manipulation than as compared to VEGF manipulation. There are studies to show that. There are two studies in which they respond better.
Yes.
The papillary variant.
We have MET amplification data also in this, where the savolitinib data in this ESCO Savior study, where they did very well in those with a MET-driven papillary type of RCC. In this ESCO, there was a good
trial was a failure.
I think patients who get IO plus VEGF in frontline using lenvatinib and everolimus, makes a good choice as a second line, where you can change the mechanism of action also and probably take care of the downstream, pathway mutation.
Yes, I agree to that. Yes.
But that Savoy trial was a failure. I think they stopped it.
Responses were 3 times, sir. If you see, there was something. If you see in terms of responses, this was the best response you got.
Response is 27% versus 7%, but the PFS was not much.
Not good. Yeah.
My question would be to everybody: if you have a non-clear cell, non-sarcomatoid, would you use IO or would you use only VEGF?
Sir, I'll answer it, sir. So there is data regarding both of them. You have to individualize the patient depending upon the condition, the comorbidity. For sunitinib, ESPN and ESPN, both studies are there with a good response. And for IO also, there is a keynote 427, that cohort B, which did quite well with a responses of around 28% in papillary type. PFS of around.
The question is, non-clear cell, non-sarcomatoid, will you use IOs? Because there is no label for that.
So I think I will use IO plus TKI.
Yeah.
IO plus TKI. Very, except for the collecting duct. Except for collecting duct, all the non-clear cell, we are using IO plus TKI.
Yeah. That both works well, sir. Both works well.
Actually, both work very poorly.
Overall, when you combine of them, that is it.
So our data is showing papillaries are not doing very well with IO TKI combinations, but then they don't do well with anything. So, but that's what we are offering at present, because there's nothing else to offer better.
So Dr. Vineet, sir, with your permission, can we conclude and then can we move to the final comments of Dr. Samir Khatri?
Yeah, sure.
Will that? So Dr. Samir Khatri, sir, over to you, sir.
So in the last nearly now 3 hours or so, we have seen how the management of RCC has drastically changed over the last decade. And this was highlighted excellently by all the speakers today. So I would like to thank all the speakers and the experts, the chairpersons, and the panelists, and all the delegates who joined this webinar. And I will also like to thank the organizers, especially my dear friend, Dr. Vineet Talwar, Dr. Rawal, and Dr. Amit, for conducting such a beautiful webinar. And thank you very much. Thank you. Thank you.
Can we have the last words from Dr. Vineet, sir, from you, and then Dr. Amit, and then if you permit, then we close. Vineet, sir.
Me and Amit both had the proud privilege of having a focused discussion on metastatic RCC, and it is, a paradigm. It is a continuum. I'll put it that way. At this point of time, we have these drugs. Go back 2 years. Well, according to the risk stratification, we didn't have much of a choice. But then, in times to come, I think we should have some tumor markers or some markers on which we can postulate which drug to use and why, and in which combination. Probably, I think that time is not far. Thank you so much. Dr. Amit?
Yeah. Thank you, Dr. Vineet. Actually, this was all Dr. Vineet's full thought process, and everything is his hard work. There's nothing I have done. So it's just that it was a wonderful learning experience, and especially from the first talk, the way it kicked off with Dr. Anurag teaching us a lot of new things. As clinicians, I feel this knowledge is lacking. We don't have that background molecular knowledge, and it was wonderful learning all this. I think we as clinicians will have to adapt this to use it in our clinical settings. And as Dr. Vineet has said, once we learn that aspect, then we will be able to choose better treatments for our patients. And I think we are improving the metastatic RCC survival much better for our patients. So thank you, everyone. Thank you very much.
Thank you. Thank you so much.
Thank you.
So thank you, Dr. Vineet, Dr. Amit, everyone. And with your permission, can we close the meeting, sir?
Definitely, Tarun, and thank you. Without you and your team, it wouldn't have been possible for the logistics and the networking which you did with great, what should I say, passion and says.
Thank you.
Thank you so much.
Thank you.
Thank you so very much. Thank you, everyone. Thank you, everyone.
Thank you.
Thanks.
Thank you. Thank you. Thank you.
Thank you.